two things. One is for oxygenation and one is for ventilation. So when I'm going to use the term ventilation in mechanical ventilation, is mainly related to CO2. And if I'm talking about oxygenation, it's mainly for O2. So there's a main difference. So even though mechanical ventilation includes controlling both O2 and CO2, but the term ventilation per se is mainly used for controlling CO2s. So this is the pathway. So you inhale the new fresh air and it will get the O2 for you. So it will diffuse it from the alveoli to the blood, and it will be carried out to the tissues where it is used for a respiratory chain and to generate energy. And apart from that, the byproduct is CO2, and CO2 diffuses back into circulation and then to the lungs, and finally it will be thrown out into the air. So there's the basic function which is happening by our respiratory system. Moving to anatomy of respiratory system, you have three levels of three-level components in respiratory system. The first thing is the controller. The controller is the brain and brainstem, and you have a ventilatory pump to suck in the air, throw the air out, and the final thing is the gas exchanger where the this diffusion process is going to happen. So ventilator pump mainly includes your muscles, skeleton, connective tissue, pleura, and nerves for this. And gas exchanger is mainly the terminal to respiratory bronchioles and alveoli. So these are the two systems, zones in the lung, normal lung. So in the conducting zone, it is of the terminal bronchioles where the air will be moving in. And there is a transitional and respiratory zones where it starts from respiratory bronchioles, alveolar ducts, and alveoli. So where the actual exchange will happen. So connecting zone and the respiratory zones are two important zones in the lung. So one important concept is the dead space ventilation. So here there are two types of dead spaces. One is anatomical dead space and the alveolar dead space. And anatomical dead space is where gas exchange will not happen. It is mainly in above the alveoli level. It includes your trachea, bronchioles. Mainly it's a connecting zone. In the connecting zone, whatever air is there, it will not be used for diffusion. And even in the if there are sometimes in the pathology when you have problem with your blood flow in the respiratory zone also, that will become like a dead space. So you can see in the image B here. So your blood flow is cut off to one of the alveoli. So this alveoli will act as a dead space. This is called alveolar dead space. When you talk about total dead space, you need to combine anatomical dead space with alveolar dead space. And this alveolar dead space usually seen in the pathology. So they can lead to VQ mismatch. So they can have ventilation, but they don't have perfusion. Some of the alveoli will be collapsed and they have perfusion, they don't have ventilation. So these are the things which will cause VQ mismatch. So the same thing I told here. And when the one mechanism, what the body tries to match the VQ mismatch is by causing hypoxic pulmonary vasoconstriction. So you can see here there is obstruction in the airway. So there is low PO2 in the alveolus. So the precapillary vessel is vasoconstricted here. So this is the major difference between the pulmonary vasculature and your peripheral vasculature. In systemic vasculature, the response to low PO2 is vasodilatation. So it's trying to move more blood so that the tissues will get the more oxygen. But in pulmonary vasculature, the response is different. If you have low O2 in the alveoli, it will lead to vasoconstriction. So that's why in pulmonary arterial hypertension and all, you are going to do more FiO2s to maintain, to reverse this hypoxic condition. So there's a main difference between your systemic and pulmonary vasculature and reactivity to hypoxia. And one more important concept is alveolar gas equation. If you not understand anything, you can please stop me because this is, I think, it's a physiology and basics, so which we can read it later on also. I'm going to move it faster because we need to go to the more important topic about terminologies of ventilation, where we need to spend more time in understanding them. This is the basic physiology, and this is from there from our MBBS, and you can always go back and read it. That's why I'm moving a little faster. But if you have any doubt, you can stop me here. So you have an alveolar gas equation. It is basically you need to calculate the partial pressure of oxygen in the alveolar level, and it mainly depends on FiO2, atmospheric pressure, water vapor pressure, your CO2, respiratory coefficient. So this is important when you have problem with your problems in your FiO. Like, mainly it is used for differentiate what are the cause of hypoxia. So whether we are dealing with the VQ mismatch, whether we are dealing with low FiO2s, whether it will be the decrease of pressure in the atmospheric pressure itself. This is what the basically equation is for. We'll see how this equation is going to help us in differentiating various conditions for hypoxia. So this is the oxygen cascade, and you start with the atmospheric air. It is like 21% of oxygen will be there in the atmospheric air. So from where you get it down at the lower respiratory tract, it will become 150, and the alveolar level it is 100, and in the arterial side of the bed it is 100, and it moves to tissue side because the tissues get extracted the majority of the O2. So your venous blood O2 will be less, around 40%, and at the mitochondrial level it will be even less. And this is one more important concept: alveolar to arterial O2 gradient. That is the main difference between PaO2 and it's a capital A and small a. So see here, this is alveolar PaO2. The alveolar PaO2 is the PaO2 at the alveolar level, that is almost 104. And P small aO2, it is the arterial PaO2 in the arterial blood. It's almost 100. The difference is very less here. So if the difference is more, what is the problem here? So say your alveolar PaO2 is 104, but arterial PaO2 is almost like 60. So what is the problem we need to find out here?
Diffusion.
Yeah, it's mainly a problem with the diffusion. So because your alveoli is filled with O2, but it is not getting crossed over to the arterial blood. If alveolar PaO2 itself is like 60, and arterial PaO2 is also 60, what is the problem here?
Ventilation.
Exactly. So it is a problem with the ventilation. So you're not able to move the air into the alveoli itself. Or it may be due to the lack of the problem with the atmospheric pressure itself. Sometimes you go to high altitudes, your PO, even the atmosphere, the air will be less, oxygen will be less. So definitely alveolar PaO2 will be less there. But there's no problem with the lung diffusion at all. So the normal range, the difference is less than or equal to 10. So if it is normal, then there's no problem with the gas exchanger. It is the problem with the other things. So we'll see how it will going to help us. And the final thing is the types of respiratory failure. So the types of respiratory failure is mainly a problem with the lungs, or it's the problem with the respiratory pump. When you have problem with the lung, so you have fall of more of O2 than CO2. Because the CO2 can easily diffuse than oxygen. So when you have lung is the problem, the alveolar exchange unit is the problem. So you have more of hypoxemia than hypercarbia. So that is called type 1 respiratory failure. When the pump itself is failure, where it is not able to suck the air in or throw the air out, then you have more of CO2 retention than O2 retention. So this is called hypercapnic respiratory failure. So why it is important? Because the intervention is going to change depending on what type of failure you encountered. The cause of hypoxemic respiratory failure are mainly divided into 5 types. So one is with the ventilator perfusion mismatch. Already we know what is ventilator perfusion mismatch. So it can be seen in any lung disease. It can be pneumonia, it can be asthma, it can be pulmonary embolism, pulmonary edema. So where you can have problem with the flow, or you can have problem with the filling of the alveoli. And second thing is you can have impaired diffusion, if you, like interstitial lung disease, or you have anatomical shunts like right to left shunt in cardiac diseases, cyanotic heart diseases, or you have alveolar hypoventilation. Mainly in hypoventilation, so the hypoxemia is predominant and hypercapnia is predominant than hypoxemia, but later on, even after the CO2 is getting up and you're not able to do some action for that, they can finally lead into hypoxemia also. And one thing is you can have low inspired FiO2 in the inspired oxygen itself. These are the main 5 types of causes for your hypoxemic respiratory failure. And based on AA gradient, you can classify them. There are 2 conditions which can have normal AA gradient. That is one thing, like your pump failure. You're not able to suck in or suck out the air, or you are having the low FiO2 itself. So those are the main conditions where your AA gradient will be normal. The rest of all the conditions where you have EQ mismatch, you have diffusion defect, you have shunting, your AA gradient will be raised. So this is about ventilation perfusion mismatch. In normal, VQ ratio will be around 0.8. And if you have low ventilation with high normal perfusion, your VQ mismatch will be less. And you have normal ventilation with low perfusion, your VQ mismatch will be high. VQ will be high. And you move on to hypercapnic respiratory failure. So the main thing is you can have a decrease in drive from the center itself. The rate can be less, the effort can be less, or your muscle failure, like in your GBS, muscular dystrophies, you're not able to generate enough effort, or your load on the your muscles and other your pump is very high, seen in lung conditions mainly. So initially, any lung condition initially will behave like a hypoxemic failure, but if they keep on worsening and they cross that your muscle load cannot bear that extent of compensation, so they finally land up in hypercapnic failure as well. The same thing like in asthma. So initially when child is hyperventilating and the initial airway collapse compression is not that much, so they will have normal CO2s. But once they keep on doing the same effort, and finally your airway narrowing can worsen, so they'll finally land up in hypercapnia. So that's like any lung condition. Initially, we can behave like hypoxemic respiratory failure, but if keep on working on the same load without any support, they can land up in hypercapnia as well. So these are the 3 main types of your hypercapnic respiratory failure. So a problem with the lung, problem with the muscle, problem with the nerves, problem with the brain. So all 4 it can cause hypercapnic respiratory failure. So this is a simple flow chart to depict what type of respiratory failure it is. If your PaCO2 is high, it's mainly hypoventilation. And then you need to check for the gradient. If gradient is normal, it's mainly hypoventilation alone. So it's a respiratory drive or it is a neuromuscular problem. But if the gradient is high, there is underlying other problem as well. So it's like lung is involved. So it could be hypoventilation plus lung, or it is end stage of lung failure. If PaCO2 is normal, then you need to look for gradient. If gradient is normal, then it's most probably it's low FiO2. If CO2, if the difference is more, then you need to look for whether it is correctable with administering O2. That's hyperoxia test. If it is not getting correct, it's most likely shunt. If it is getting corrected, it is VQ mismatch. So this is a simple algorithm where how to differentiate your respiratory failure. And why it is important? Because we need to know what the treatment you need to give for these failures. In primary hypoxemic failure, it's mainly oxygen therapy. You don't need much amount of support initially. But later, when a child is failing too much, then you need to give appropriate support. But in respiratory failure, pump failure, you cannot give just oxygen for the desaturation. You need to straight away start some amount of support in for positive pressure in NAV or ventilation. So that's the main difference. For hypercapnic failure, just don't give oxygen and wait because it is not going to work for that child. And even that oxygen that eliminating the hypoxemia can decrease the further drive for the respiration. So you need to go for some amount of support directly. But in hypoxemic failure, you can try oxygen first, then you can go for mechanical ventilation. So what are the common indications for positive pressure ventilation? So we have gone through the different amounts of different types of respiratory failure. So now I need What are the common indications you are going to initiate mechanical ventilation? It could be invasive, it could be non-invasive. You can unmute and answer. Indications for mechanical ventilation in a child. You can broadly classify them also. No volunteers?
CNS pathologists
CNS pathologists, examples?
like in newborns, HI, severe HI.
Why you are ventilating? Why you need to give mechanical ventilation for a
No
child?
drive, no respiratory drive.
So
Controllers are not working.
yeah, it's not only about the control in CNS issues. There is another thing also. You are ventilating, even if they have drive, if they are breathing, you need to ventilate some of the CNS cases, right?
Like high raised ICP.
Yeah, recipe. Common. I'm not asking about real.
During surgeries.
No, surgery is one of the cause, but I'm talking about in CNS. In CNS, even if child is breathing, you need to do mechanical. You need to put the ET tube. Specifically, you need to put the ET tube.
Head trauma.
Why? I'm not talking about different types of cause of CNS. I'm talking about any child with CNS issue. You need to put ET tube. I'm giving the clue also.
Impaired consciousness.
So impaired consciousness. Why are you intubating that child?
Respiratory drive will not.
No, the child
Effort will not be there.
What?
No.
Child is having drive. Child is breathing at a rate of 30. His O2 is normal, CO2 is normal. Still, I will go for mechanical ventilation by ET tube, not by NIV also.
For cerebral perfusion.
No?
But to avoid aspirations.
Exactly, to protect the airway. So this is the commonest indication for mechanical ventilation in a CNS issue. It is not your raised ACP, it is not your absent of drive. So majority of them will have drive. This is only in brainstem involvement or late stages of your raised ACP only you will have suppressed drive. So it's mainly to protect. So in CNS you have two indications. One is the pump failure, or you have to protect the airway in low GCS. And second thing, like someone told, for the surgical purpose. And third, which patients need support?
Hemodynamically instability.
The hemodynamic instability. So, but you're not talking about commonest causes. Any child with respiratory failure needs some sort of support. Whether it is hypoxemic failure or it is hypercapnic failure, they need support. In hypoxemic failure, initially you can try with only with oxygen, but if this is a moderate or severe disease, they need some amount of support by mechanical ventilation. It could be NIV, it could be intubation, invasive mechanical ventilation. So unprotected, unstable airways, you need to do mechanical ventilation, mainly by invasive. And hypercapnic respiratory acidosis, you need to give support. And hypoxemic, if you have only problem with muscle and nerves, you don't need to go for invasive ventilation. Like if a child with GBS with respiratory paralysis, you can always try non-invasive. But any child with low GCS, if they are not having drive, or even if they're not able to handle secretions, you cannot try NIV. That's what I'm telling you. You need to be very careful when you're choosing what type of modality of mechanical support you need to give, whether you have to go for non-invasive or invasive. It depends on the underlying indication why you are to provide the support. So don't go for NIV in a child with some amount of CNS disturbance where he cannot handle his secretions. So even though it can help in reducing the CO2 and giving oxygenation, but it's not the main issue there. Main thing is to protect the airways. So another thing is hypoxemic respiratory failure, and like it will sometimes for you go for surgery, especially for bronchoscopy. So you're going to do the mechanical ventilation. So with this, we'll finish the background of what is the respiratory physiology and what is the respiratory type of respiratory failure. So with this, we will move on to the what is the thing we need to discuss about mechanical ventilation, about the ventilator, how it works, what are the various terminologies we use in mechanical ventilation. So I think from this, I think we need to have interaction, and I need some of you people to talk more than me, so that we can learn from each other. And this is the ventilator working principle. So you can see here that this is the first thing. Can you see my arrow mark? Is it visible? Arrow mark on screen.
Yes, sir.
Yes, sir.
Yeah. Just see here. This is the starting of the breath. The mechanical ventilator is giving a breath, and it was connected to a high pressure gas source. So you always know that you're going to connect two pipes into the oxygen sources. One is the O2, one is the normal air, medical air. So from there, the gas source will be very high pressure, and you have two valves which will control the gas flows. One is the inspiratory valve and the expiratory valve. Now the patient has to move to inspiration. So to move to inspiration, which valve has to open up?
Inspiratory.
Inspiratory valve.
Inspiratory valve. Why both cannot open up? Inspiratory and expiratory? You can open both inspiratory and expiratory. No, air can flow in. You can see in this diagram, the expiratory valve is closed. It is not open.
So for ventilation, we need resistance to expiratory valve.
Resistance to expiratory valve. Can you explain it?
Mm.
No, I am not talking about. No, I am not. I am talking about inspiration. I am not talking about expiration at all here. So this is.
To deliver whatever pressure we are giving, there should be not any leak.
Yeah, it's like you should. If you open expiratory valve, simultaneously inspiratory valve, the entire pressure what you're delivering in will be taken away, existed out. It will not go directly to the lung. It will be only partial things going to the lung, and partially it will be gone out. So you don't have any control over how much amount of the pressure you are delivering into the lung. So that's why you should never allow both the valves to open simultaneously. So we are not going to control it. It's already programmed. The ventilator is programmed like that. During inspiration, the expiratory valve should be closed. That's all. So how much amount of the pressure you set for inspiration, that only will be delivered during inspiration, and this valve will be adjusted like that. So it will not allow the entire pressure from the gas source to reach it. So this valve will control how much amount of the pressure going to be delivered to the lung. Say your gas pressure, what is there in the your main source is around 100 to 200 pascals, and what we need is only 20. So this valve will act, it will open so much that it will allow only 20 pressure to be delivered in. So that finally it is going to be reached to the alveoli. So that's the main principle in this control here. And this expiratory valve will be closed because it will not take away the water pressure delivered. So total amount of pressure delivered in will be stayed in the alveoli. And finally, once you deliver the pressure, so 20 is delivered, what should happen to inspiratory valve?
It should close.
It should close so that it keep the pressure same throughout the inspiration. And throughout the inspiration, your expiratory valve will not open up. If it's open up, you're not going to maintain the pressure during inspiration. So that's why during inspiration, expiratory valve is totally closed. At the start of inspiration, your inspiratory valve will open, but once the desired pressure is reached, it will start closing. And finally, at the end, when a child moves on to expiration, and the ventilator will open the expiratory valve. And how to maintain PEEP? Any mechanism you want to tell how to maintain PEEP? Because if you open the expiratory valve fully, your pressure will become 0. And how the ventilator controls this? The same thing like how it controls the inspiratory valve. So by controlling the expiratory valve, you can decide how much amount of the pressure to go out. What is the pressure, desired pressure reached to, like say, I want to set a PEEP of 6 and the total pressure is inside 20. So it will let out the 14 pressure out. And once the 14 pressure is gone out, the expiratory valve will be closed. So the 6 pressure will remain inside. So it doesn't happen throughout the expiration. The pressure will be remain same. What is that called? PEEP. And once the start of inspiration, again, the ventilator will decide how much amount of the pressure to be gone in by controlling the inspiratory valve. So this is the basic principle, which is main algorithm for your mechanical ventilator to follow. It's very simple. The mechanical ventilation algorithm for a ventilator is very simple, but there are different modes and different things how to give this pressure. So we'll be keep on discussing about that kind of things in the next couple classes. But this is main the basic principle. So you have a high pressure source, and you have two valves which can control how much pressure will be released in or taken out. So there's a main control for the ventilation. So with this actually more the terminologies. The terminologies are mainly the snapshots of your ventilatory pump. The common terminologies are pressure gradient, volume, flow, resistance, compliance, and time constants. We'll go through one by one. So don't worry about definitions. I'm not going to talk about definitions. The pressure is the force applied over unit area. It will be measured in bars, kilopascals, centimeter of H2O. So there's so many units for measuring pressure. And the pressure difference between two areas is delta P or pressure gradient. So that's all. This is a difference. And we need to know about certain pressures in respiration. So you start here. My arrow mark is moving.
Yes, sir. Yes, sir.
Start with the pressure here. This is the opening pressure of the airway, opening pressure, PAW, or mouth pressure. So this is the pressure at the starting of your respiratory tract, which almost like this is the pressure needed to push the air into the alveoli. And for that, you need to overcome two things. So one is the airway resistance here. Second thing is the elastance of the alveoli. So these are two main opposing forces. So to overcome these two forces, you need to give certain pressure, and what the pressure needed is the opening pressure. And what is the pressure here in the your respiratory airways is P airway pressure, and what is the pressure in the alveolus is P alveolar pressure, and pressure in the pleura is pleural pressure. And we need to know about certain gradients here. The first gradient is transpulmonary pressure. The transpulmonary pressure is the pressure, the main difference between the pleura pressure and alveolar pressure. It's like lung pressure. It's called transpulmonary pressure. So you subtract from the alveolar pressure minus pleural pressure, it will give the transpulmonary pressure. It will be very important in certain mechanics during mechanical ventilation. And the other thing is the transthoracic pressure. Is the main difference between the pressure at the surface, body surface, to the pressure of the alveoli. And trans airway pressure. Trans airway pressure is the pressure at the starting of the airways, and the pressure in the alveoli. Why this trans airway pressure is important? What it going to tell you? And what is the transpulmonary pressure importance? These two are very important for us. What is the transpulmonary pressure and what is the trans airway pressure? What it tells trans airway pressure to you? I already told you, you need some pressure to overcome two things. One is resistance, other thing is elastance of alveoli. So we have two pressures here. So you need to tell me which pressure is going to act on which. I'm not asking any extraordinary things here. I was just asking basics that you're following me or not. So you have a total pressure which is needed to overcome two forces. One is the airway resistance, other thing is the alveolar elastance. Alveolar elastance is nothing but resistance to stretch, that's all. Resistance is that it will not allow the flow to go in. So now you have two pressures. One is trans airway pressure. That's the main difference between alveolar pressure and the airway opening pressure. And second thing is transpulmonary pressure is the pressure in the difference between alveolar pressure and pleural pressure. So you have two forces and two pressures. So you need to match which is acting to overcome which force.
In transpulmonary pressure,
Yeah, transpulmonary pressure.
plural
Okay.
negative.
So it is used to overcome which pressure, which force. Simple. My question is there are two forces, two pressures. Don't read.
Plural.
One force is resistance, one force is elastance.
Elastance.
Primary pressure is to overcome which force? Elastance.
So airway pressure is for
Transairway is for resistance.
Pulmonary.
transpulmonary pressure is for elastance.
Transpulmonary elastance. That's all. So if you don't understand this, it is very difficult to make you understand other concepts. That's why I'm staying here to discuss. So I'm not complicating anything here. That's what I'm telling. I'm talking very basics. So if you don't know what is transpulmonary, trans airway, it's fine. The meaning itself is there. Trans airway is, it's about airway. So airway, what is the force in the airway is resistance. That's all. So I'm already giving the clues. I'm not asking you to talk about what I don't tell to you. So please keep following with me, because if you don't understand these concepts, the subsequent concepts will be very difficult for me to explain. I hope you people understand what I'm talking. So transpulmonary pressure is the pressure which is needed to overcome elastance. That is the force which is resisting the stretch of the alveoli. And you have one more pressure is trans airway pressure, which is needed to overcome your airway resistance. So these two forces and pressures are very important in understanding different pathologies and different settings. So we'll move on to what is going to happen in normal respiration. So you can see here during normal inspiration in a spontaneously breathing patient. I'm not talking about mechanically ventilated. In a spontaneously breathing patient, so what will happen to your pleural pressure during inspiration?
Negative.
Everyone agree with this?
Yes, sir.
Yes.
Yeah. So because you are contracting your diaphragm and inspiratory muscles, so they will stretch the chest cage. So it will create a suction like kind of thing. So your pleural pressure is always negative, but it will become more negative during inspiration. So that creates a gradient. So what is your airway opening pressure at that moment? The pressure at the starting of respiration, respiratory tract. It's atmospheric pressure.
Intra.
It's atmospheric because you are exposed to atmospheric. So we'll take that as a 0 usually. So atmospheric pressure will be taken as 0. So your pressure in the pleura will become more negative. So you see here -5 initially, and it will become -10 during the peak of inspiration. So 0 minus 10 will become 10. So it will create a gradient for the air to move in. And again, when your lung stops inspiration and going to expiration, whatever the stretched tissues will recoil again. So the lung will move back. So your pleural pressure from -10 will move back to -5. So again, the air will go out. So this is what going to happen. So see here, follow my arrow mark. So during inspiration, your pressure becomes negative, and during expiration, it will become almost positive side. So this is keep on happening. So during inspiration, your alveolar pressure will be less than your airway pressure. That's why your air is sucked into the alveolus. And during expiration, your alveolar pressure becomes positive. So that's why the air will move out. That's mainly because of your recoil. So your muscles are not doing any action here. Only during inspiration, you are doing some action. Your muscles are doing action. So it is called active process. But during expiration, it is not doing any work. It's because you already stretched the tissue, it will recoil back. It's like a rubber band. For rubber band to expand and stretch it, you need to do work. But to make it to come back to normal previous size, you don't need to do any work. The same principle applied for the lung as well. So during inspiration, you are doing work to get the air in. So it is called active process. During expiration, you are not doing any work. It's just the recoil of the stretched tissues, which is doing the work. So it is a passive process. It's very important. This concept of active and passive is very important because we should be discussing subsequently about how to manage CO2 retention and all based on these concepts only. And what is the difference between the respiratory pressures when you are on mechanical ventilation or positive pressure ventilation? The main nowadays what you are doing is positive pressure ventilation. We are not doing negative pressure ventilation. In the olden era, they are doing negative pressure ventilation by iron lung machine, where they will create a negative pressure to expand the your chest wall along with the lung, and during expiration they just release the pressure so that it will recoil back. But now the modern ventilation is positive pressure ventilation. We never almost we forgotten about negative pressure ventilation. So in positive pressure ventilation, you can see here your pleural pressure is becoming positive. Why? Because the ventilator is pushing the air in. Here during inspiration, your pressure is becoming positive, and during expiration, it's becoming normal. It's now becoming negative here. It's just becoming positive from 0. It's becoming positive, and it's becoming to baseline. It's never becoming negative here. And during inspiration, your airway pressure is more than the alveolar pressure, and during expiration, your airway pressure is less than alveolar. That's why your air is going out during expiration. It's just opposite to your normal spontaneous breathing ventilation. So this is mainly positive pressure ventilation. And the main question here is, what is active process here? What is passive process here? Inspiration, expiration. Which is active, which is passive? Or both are active, both are passive?
Inspiration active, expiration passive.
Why you are talking inspiration is active here? You are doing any work here? All agree with her?
No.
Is correct. Inspiration is active, expiration is passive. And how to justify inspiration is active here? Even if you give neuromuscular block, he will get the tidal value for him without generating any effort. See, this active or passive process is not you are doing the work. If someone is doing the work. Here, instead of you, who is doing the work?
Yes.
Ventilator.
Yeah. So ventilator is doing the work for you. So even if ventilator is doing the work, it is active. During expiration, ventilator is doing any work?
No.
So it is passive. Even on positive pressure ventilation, you cannot control expiration. Expiration is dependent on your lung mechanics. You cannot control it with ventilator. So this is the first thing you need to remember from this class. Even on ventilator, conventional ventilator, your expiration is always passive. Why it is important? So we need, when you are discussing about asthma ventilation, we'll know this. Just remember this concept that inspiration is always active, expiration is always passive. The only exception for expiration is active is your HFOV. Will be discussed subsequently. I hope I'm clear on this. Any doubts for these 2 slides? You need to go back and read again. It will not be incorporated in 1 or 2 sessions. So you have to keep. So I'm going to provide these slides. So please keep reading about this. So then only you can understand. And if you have any doubts, you can ping me or you can discuss in next class. Is it clear? Still no any doubts?
Yes, sir.
So the same thing is depicted here, different types of mechanical ventilation. You can see here, and HFOV, it will keep on oscillating around the baseline. The pressure is constant, but the oscillations will be keep on moving around the baseline. You can see here, it will be moving in one direction only. In positive pressure ventilation, it will be moving in a positive direction. In negative pressure ventilation, it will be moving in a negative direction. And finally, reach the baseline. The baseline pressure is always PEEP. So you will never go below that, or in negative pressure, you won't go above that. So this is the positive pressure ventilation, the first one. This is the negative pressure ventilation. And this is the HFO, which will be oscillating around your airway pressure. So this is a summary slide for your thing. So in spontaneous ventilation, inspiration is active, expiration is passive. Even on mechanical ventilation, positive pressure ventilation, expiration is always passive. Only in HFOV, it is active. Inspiration is always active. Either you are doing the work or ventilator is doing the work. It will never be passive. So now we'll move on to the different pressures. The most important pressure is PEEP. So what is PEEP?
True and expiratory.
Functional residual capacity.
Madam Ji, I don't want,
Mhm.
I just want what is PEEP.
Positive
What is function?
Positive index.
Positive and expiratory pressure. Okay, so where which phase you are going to get it?
Experience.
At the end.
You are going to get it in the expiratory phase.
Experience.
That is enough. P peak. What is P peak?
Pressures at the end of inspiration.
Pressures at the end of inspiration. Correct? Everyone agree with her? I will not agree.
PEEP.
Anyone want to give a better definition for that? The name itself is explaining, man.
Mhm.
Peak pressure in the
Pressure.
respiration.
This is the peak pressure that the lung can achieve during inspiration. It is not at the end of inspiration. It can be at any point. So this is the maximum pressure achieved during inspiration. That is P peak. What is delta P?
PIP minus PEEP.
P
PIP minus PEEP.
louder.
PIP minus PEEP.
Okay, P peak minus P. Okay, that is delta P. Fine. And what is P plateau? You can see here. So from here you can explain me what is P plateau.
Pressure at inspiratory pause, measure at inspiratory pause.
No, I'm not asking how to measure it. I want what is your understanding of P plateau? We all go how to measure it and all subsequent class. I don't want to bother you about that.
Average pressure of alveolar resistance.
No, that is not the definition. You can explain it. If you're not able to define it, you can explain it. Or you can just simply tell me what is that pressure P plateau in the different pressure you've seen in the previous diagram. Here, you can explain what is the pressure, which pressure you can label as P plateau here.
Airway pressure.
P plateau is airway pressure. See the diagram.
Alveolar.
See the diagram here. Where is the P plateau here?
Pressure on alveoli.
Yeah, pressure at the alveoli. See, you have taken off the resistance here. Your resistance you taken off. And once you remove the resistance, what is the pressure needed to work on the resistance? The rest of the pressure is the P plateau, and it's mainly needed for distending the alveoli. Alveolar distending pressure, it's almost similar to a transformer pressure. It's not exactly like that, but if you see in the previous mechanics, that's what we can tell. So PIP is the total pressure needed first to overcome resistance and also to distend the alveoli. So it is in the previous slide, what it will be now?
Alveolar.
Trans airway plus
PIP is which pressure here?
trans airway
pressure.
pressure.
No. Trans airway pressure is only the pressure needed to overcome the resistance. But PIP is to overcome both forces.
Trans airway plus alveolar.
So it is also equivalent to opening pressure, airway PAWO. That's the pressure you are going to apply to the mouth, right? And this is the one which is going to apply, and that is the one which is going to overcome the resistance, which is going to overcome the elastance. So it is the PAWO, airway opening pressure. It's almost equivalent to your PIP. It will be confusing only, but take your time to understand this. These concepts are important for us. And at least you know that PIP is the total pressure needed. It is needed to overcome the resistance, and it is needed to overcome the elastance. And if you take off resistance, just remove the resistance, then what is the pressure needed? It's just to overcome the elastance. The pressure what is needed to overcome the elastance is P plateau. Alveolar distending pressure. If you combine alveolar distending pressure with the pressure needed to overcome the resistance, it will become PIP. Is it clear what is the difference between these two? So normally you have to do more work to distend the alveoli than overcome the resistance. The gap will be less. Normally the gap between P plateau and PIP will be minimal. But where you can get more gap here, the difference between PIP and P plateau will be more in which conditions?
Bronchospasm.
When you have increased airway resistance, like your asthma, bronchial. So there the difference will be more. So your P plateau will be way less than the PIP. So that is why you have to think about, if I am needing more pressure to overcome resistance, that means my airways are not normal. That's a bronchospasm. I need to deal with it. So P plateau is measured by blocking the inspiration for at least 3 to 4 seconds. And you can do it by putting a button on the ventilator called inspiratory hold. Once you push that button, inspiratory hold, keep pressing that button, and you will stop the airflow or the inspiration, or the peak of inspiration. So now air is not flowing. If air is not flowing, then it's not needed to overcome the resistance. And whatever pressure is needed now is just to inflate the lungs. So that inflating pressure is P plateau. When the flow is zero, what is the pressure needed to keep the alveoli open is the P plateau. Not open, it keeps distended. PIP is combined of both. It is the pressure needed to overcome the resistance plus pressure needed to distend the alveoli. So this is the table what this is the graph I'm showing here. So when you have high airway resistance, the gap will increase. See here. This is the normal gap. Normal gap will be very less. In high resistance, your PIP will go up. P plateau will be normal. But the difference mainly here is your increased airway pressure. What are the resistance? Trans airway pressure. See here, in your case of lung problem, like parenchymal problem or ARDS, where your lung is very stiff, you need more pressure to distend the alveoli, and your trans airway pressure will be normal, so the gap will be less. So by seeing this kind of graphs, you can easily pick out where the problem. The problem is with the alveoli, or the problem is with the airways, by just measuring the difference between PIP and P plateau. So it is very important when you have a confusion in bronchiolitis children. So you feel that this child is more of airway, and you keep increasing some settings, but child is not responding. You want to know whether it's not only airway, whether this is also a pulmonary lung problem as well, a parenchymal problem as well. So just to measure the P plateau, the difference is more of airway problem. The difference is less and P plateau is high, it's more of parenchymal problem. If both are the P plateau is high and difference is more, then it's a combination, mixed problem. So that's why you can change your strategies. The next important concept is lung volumes. So you have different lung volumes. So one is total lung capacity, tidal volume. What is tidal volume? Quick, we need to move on. What is tidal volume? Come on, man. What is tidal volume? Just explain it. No need for strong definitions for me. Just explain what is tidal volume.
Volume of air
Inhaled and
Normal respiration
during
air
this,
Volume of air moved in or moved out during normal respiration.
during normal respiration.
That's all. That is tidal volume. So what is FRC?
After normal amount
Total of pressure
What is the air
present in the lungs after
present in the lung? That is not the left out. What is there remaining in the lung? Normal expiration.
during normal
Deep
respiration.
expiration. It's a normal expiration. That is the FRC. The residual volume is the volume what is remaining when you have forced expiration. Just remember these three. That is enough for us. One is tidal volume. It is the volume of air moved in or out of the lung during normal respiration. FRC is the volume of air in the lung at the end of normal expiration. Residual volume is the air in the lung at the end of forced expiration. Just these three is enough for us. What is minute ventilation?
of the respiration.
So it is the amount of the air pushed in or pushed out in 1 minute. It is a combination of tidal volume into respiratory rate. Just remember this formula. So another important concept is critical closing volume. What is critical closing volume? Critical closing volume. The name itself will tell you what is this.
Initial.
So it is the volume below which your airway started closing. So your alveoli will start collapsing. So what will be the normal relation between functional residual capacity and closing volume in a normal lung?
inversely proportional.
There is no inverse or directly proportional. I am just asking which is more or which is less.
Functional
critical
capacity is more.
will be less.
Yeah. So critical closing volume is constant. It will never going to be changed. It is constant for any lung. In normal lung, you need your FRCB to be above this or below this to keep
Above.
the alveoli open.
Above.
Above. So in normal lung, your functional residual capacity is above the closing volume or closing capacity. So you can see here, this is the normal lung, this is the FRC, and FRC is above the closing capacity. And you have certain problems, certain pathologies in the lung which can decrease FRC. Can you label that problems? So we have discussed some lung conditions in the hypoxemic respiratory failure. Which lung conditions can decrease FRC?
Pneumonia.
Any problem with lung parenchyma. So they can decrease liquid pneumonia, pulmonary edema, ARDS. All these things decrease FRC. So the FRC will now become below the closing volume. So what will happen to your lung?
Collapse.
Alveoli will
Collapse.
So that's the most important concept you need to remember. This is very much needed in managing parenchymal problem patient, because that is the common children you are going to ventilate. Without this concept of FRC and critical closing volume, you will not understand how to manage them. So again, I'm telling, remember these two volumes. One is functional residual capacity. It is the normal volume in the lung at the end of normal expiration. Critical closing volume is the volume below which the airway or alveoli will start collapsing. And in normal lung, your FRC will be above the CCV. That's why your lung will not collapse in normal when you are normal. But during certain pathologies like parenchymal problems, your FRC will go below CCV. Don't tell CCV has moved up. CCV is increasing. CCV will not move up. Your FRC gone down. So that's why your lung tends to collapse. So what is the physiology? What is the implication of this? We'll discuss in this specific ventilation topic. So next parameter is flow. The flow is the movement of the gas over time. So it is volume by time. That is what flow. And you can see here there's a different types of flow patterns. One is sinusoidal flow. Another thing, decelerating. Decelerating is quickly the flow will become the maximum and suddenly it drops down. So this is during inspiration. I'm not talking about expiration. Expiration is passive. So you don't have any control over your flow. You can see here during all the expiration, all the varieties of flows, the expiratory flow is same. It is not going to change. It is going to change only with the airway problems. It's never going to change with any other problem. And ventilator has no control over expiratory flow pattern. It doesn't control expiratory flow pattern. So you need to look at that one point. So your the graph below the line will never going to be changed by your ventilation strategies. And only thing what you can control is the above pattern. You want a decelerating flow, that means peak of the flow and then decelerating, the exponential, it will fall down. And constant flow. So when the pressure reaches to a certain extent, it will be constant throughout the inspiration and then it start falling during expiration. And accelerating flow is like slowly the flow will become to peak, then it will fall down. So based on these different flow patterns, you see your volume curve here, it is going to change here. The sinusoidal, you're almost having a sinusoidal volume. And decelerating flow, you'll quickly have the volume and it will come down. Constant flow, slowly your volume will build up and it will come down. And accelerating flow, again, it's going to slowly, your volume going to peak the peak and it will come down. So based on this, your pressure also will change. In sinusoidal, it will be sinusoidal. But when you have decelerating flow, your pressure will be constant. Like you can see here, the graph will be very constant. And you have a constant flow, the pressure will slowly build up. It will be like accelerating pressure. And then accelerating, it will almost accelerating flow. Just remember these two flows. One is the decelerating flow, one is the constant flow. In decelerating flow will become the peak immediately and suddenly it will going to start falling exponentially. And in constant flow, the flow reaches to a certain extent and it's going to stay there for total the inspiration. And the peak flow what reaches here may not be equal to the peak flow what reaches here. The graph is very not normal here. It's the wrong one here. It will be like just half here. The peak will not reach here. The peak will only reach here. So that's why the peak flow reached here will be always more than the peak flow reached in the constant flow. And the pressure curves will be like this. So this is the constant pressure curve because you have a decelerating flow. The pressure already reached the peak. It's going to stay there for during inspiration. And you have constant flow, the pressure is slowly going to build up. So it will be like a curve like this. So just remember two flows. One is decelerating flow, one is the constant flow. We'll see, they are very important in depicting the modes. So that's why just remember this concept of decelerating flow and constant flow. The next important is the breath cycle. Breath cycle contains inspiratory phase and expiratory phase. And the normal inspiratory-expiratory ratio is 1:2 or 1:3. And how much amount of time you're going to spend in each cycle depends on respiratory rate. So if you have 30 breaths per minute, what is your breath cycle? You have 30 breaths per minute. So what is the breath cycle now? How many seconds?
2 breaths.
2 seconds. And you kept a E ratio of 1:2. So what is the inspiratory time and what is the expiratory time?
0.6
0.6 will be inspiration.
0.5.
Yeah.
0.61.
No, 0.6 and 1.3. 0.7 and 1.3, that is what you have to do. 0.65 and 1.35 is the actual one. So depending on that rate and depending on your IE ratio, your inspiratory and expiratory is going to change. They will not be able to constant until unless you just controlling the inspiratory time. Never you can expect a constant inspiratory and expiratory times when you're going to change the rates. The majority of the ventilators, you set the settings like you set the rate and the IE ratio. So based on the rate and IE ratio, your I time and E time is going to alter. So when you're increasing or decreasing rate, you need to be very careful about how much the I time is actually going to deliver. How much of the E time is going to be there. It's very important in asthma ventilation, where if you keep on increasing rate, your time for expiration will come down. So that's why your CO2 is going to further build up. So be vigilant about this. So when you are altering the rate, the I and E time is going to alter. So you need to be very careful when you are altering the rates without altering IE ratio. The compliance is nothing but changing volume by changing pressure. So this is the curves which is going to depict when you have increased compliance or decreased compliance. So if you have decreased compliance, what is the main difference in the pressures needed to generate the same volume? So your compliance is less. So what is
More
the
pressure.
Yeah, you
More
need
pressure we need.
exactly. So you can see here, you have stiff balloon. For stiff balloon, to inflate it to the same diameter, you need to do more work. And this side, you need a very thin balloon, a fluffy balloon. So the needed to inflate is very less. So if you have a low compliant lung, you need to do more, you need to give more pressures to generate same tidal volume. And if you have a highly compliant lung, you need to give less pressures to generate same volume. So this is very important. So what are the examples of low compliant lung?
RDS.
Pneumonia.
Parenchymal problem.
ARDS.
Yeah, pneumonia, ARDS, and pulmonary edema. So these are the diseases where you have low compliance. So that's why you need to have high pressures to ventilate them. So one more concept is hysteresis. So there are two graphs here. One is just inflating the lung with saline, and another one is inflating the lung with air. In saline, you can see here, they just go up and come down in the same pathway. But here you can see the inflation curve. That is, when the lung is inflating, it's different. When the lung is deflating, it's different. And what is the compliance when compared between inflation and deflation curve here? What is the compliance in deflation curve? If you tell this answer, I think you people understand the concept very well. Compliance is
More in
volume,
air.
change in volume and change in pressure. So
More in air curve, sir.
more in expiratory curve. No, I am not talking about saline and air curve. I am talking about deflation limb of air curve and inflation limb of air curve. Just compare. Compare the
Sir, at higher,
pressure. Just compare the pressure. So I am putting the pressure here.
sir, at higher pressure, the inflation compliance is more, sir.
No. You are taking me wrong. See here. See here.
Compliance
Pressure is zero. Just follow my arrow mark.
Not in.
The pressure is 0 here, right? Now I'm moving the arrow mark to here. So now you tell me what is the volume on deflation limb and what is the volume on inflation limb.
More in deflation limb, sir.
Yes. So where is the compliance? More.
More in deflation.
Now you understand what I'm telling.
Yes, sir.
That is called hysteresis. Why it is there? Because of the surface tension. So when you alveolar collapse are very having less volume, the surface tension is very high. So you need more pressure to work on the surface tension. Once you opened up the alveoli, then you need less pressure to distend it further. So in inflation, you're doing more work here. See here, you are getting moving, but suddenly you reach a point where the compliance is increased dramatically. And again, at certain point, it is becoming low because you over distended here again. Once you over distended, you are going to get the low compliance because the over distended alveoli is going to compress the normal alveoli again. So the main difference you can see here, during deflation limb at same pressure, you are getting more volume. It is mainly because of surface tension. Once you distend the alveoli, the surface tension will be less. When you start at the collapsed alveoli, the surface tension will be more. That's why it will not allow the alveoli to stretch. So you need to have more pressure. So during deflation curve, your pressure needed is more to get the same volume. But during a deflation curve, your pressure needed is less to keep the lung open. That's the main thing. The concept here is to open the lung, you need more pressure. Once you open the lung, to keep it open, you need less pressure. That's all. Is it clear what I'm telling? To opening a collapsed alveoli, you need to do more work. But once you've done the work and your alveoli is opened up, to keep them open, you need to do less work. How it is important, we'll discuss in ARDS ventilation. It is very important for ARDS ventilation. So I just called it here. We have to keep revising all these concepts later on also. So this is very important when in ARDS ventilation. It's mainly important for PEEP titration. So this concept is very important for PEEP titration. We'll discuss in this later on again in the PEEP titration. So resistance is the mainly it's the force against the gas movement. It's inversely proportional to the radius square. So when your diameter of the airway is less, your resistance will become 4 times more. So that is the more important. This concept is very important for us in asthma ventilation, where your airways are narrowed down because of so there you have more resistance, and the resistance is overcome by your trans area pressure. So trans area pressure is the difference between P peak and P plan. And this is the picture depicting that the resistance is not high according to your formula in the lower airways. See here, when you told previous slide, resistance is inversely proportional to radius power 4. So where you expect resistance, which airways will have more resistance according to this formula?
Small airways.
Small airways. That is not correct. See here, which airways having more resistance?
Larger airways.
Not large, it's medium airways. So large airways, they are compared to small airways, even large airways are high. But the maximum is at the 5th and 7th generation. This is the medium bronchioles, medium sized bronchioles. So where your asthma pathology will act. The asthma is not going to happen at the trachea and bronchial level. It is a bronchial, small bronchial level, the medium level, and it's not at the terminal bronchioles level. So see here, The main concept here is the smaller airways will be arranged in parallel. So they'll be keep arranging in the parallel, so they will feel like they'll have more diameter. So they'll be keep running in the parallel, so they'll have low resistance, because when they arrange it in parallel, the air has to move all of a sudden, it will move easily, rather it's going through to one channel. So that's the main concept here. So your airway resistance is more at medium, not at the lower level or the higher level. So another important concept is time constant. The time constant is the amount the time taken to move in air or out. The one time concept is 63%. So it is a 63% of the air to move in or out among the total air. Say if you have a tidal volume, if you want to move the volume of 1 liter, and how much amount of time taken to move 630 ml is one time constant, and second time constant is how much to move 860 ml, and third time constant is how much to move 95. So our main target is at least to give 3 time constants. When you are setting inspirated time or expected time, you need to make sure that you are giving enough time for the inflation and deflation. If you're not giving adequate time, if you're giving only one time constant, that means you're going to fill it only 63%. You understand what I'm telling? So the minimum I time or E time is at least 3 time constants, and you're not going to measure it. No need to worry about how to measure this time constant. You're not going to measure, but understand the time constant. So you should know which time you need to give more, which time you need to give less, in which pathology. Someone told not understood. What? Not understood. I'm not talking anything extra here. I'm just telling you that time constant is the time needed to inflate or deflate certain amount of air. One time constant is 63%. That means if I have a tidal volume of 1 liter, I need to move 630 ml of air into the lung. The time taken for moving this amount of air into the lung is one time constant. Next, second time constant, that is two time constant is 86%. Amount of air, 86% of the amount of air is to move inside, that is 2 time constant. If I move 95% of air into the lung, that is 3 time constants. Is it clear what I'm talking? The same applies for the expiration also. So to move 63% of the air out, it is 1 time constant. To move 86% of air to out, it is 2 time constant. To move 95% of air out, it is 3 time constants. And this is very important because these time constants can alter in different lung pathologies. See here, this is a normal lung. So the time constants are normal here. And the B curve is you have a low compliant unit. Low compliant unit is airway problem. So airway problem, the time constants are less. It can quickly fill, it can quickly let out the air. But if you give the same pressure, the total amount of the volume going to go into the lung will be less. You can see the difference here. In these two curves, time is same. You give the same time, but what is the volume generated here in the curve B? Less. It's because of you give the same pressure. But if you give more pressure and if you give the same time as of the normal lung, they can fill it to the full. Okay? But the concept in airway resistance, in airway problems like asthma, it is different. Here, you give same time like for the normal lung and same pressure. What is the volume you're going to get?
More volume.
More volume, sir.
Same time as of the normal lung and same pressure. Think. Don't see the curve there. That's what the curve is confusing to you. That's why we don't discuss the curve. I will explain it later. See, the pressure, what the PAP is the pressure, what is needed to overcome which forces?
Resistance.
Only resistance.
Both
Both, right?
Alveolar plus
both
resistance.
airway alveolar.
Why you are getting low volume in curve B in low compliant lungs?
Less
Alveolar
More
resistance.
You have more resistance to the stretch. There's more elastance. That's why the pressure is not sufficient. That's why you're getting low volume. Then what is the problem here? Which force is more here?
resistance.
Airway.
Airway resistance.
Then how can you get normal volume? High volume?
More.
You understand what I'm saying?
Residual. Sir, already residual volume is more.
No. Don't think about it. That's what I'm telling you. You forget about this. I am just talking about tidal volume. I am not talking about total lung volume. Is it clear?
Yes, sir.
Is it clear? The
Yes, sir.
pressure what you are giving is to generate tidal volume, not a total lung volume. Total lung volume is different. Total lung volume is not going to take part in gas exchange. How much amount of air in the lung, it is useless. What is needed is a fresh air with more O2. Is it clear? So in airway problems, you need to give more pressure to overcome resistance. If you don't give more pressure, you don't get your desired tidal volume. Is it clear?
Yes, sir.
But if you give same pressure or more pressure, but if you don't give enough time, or you give same time as such of the normal lung, does you're going to get same tidal volume? My question is clear. I am telling, I am going to increase the pressure to overcome the resistance. So resistance is say extra pressure of 10. I give an extra pressure of 10 now. Thus, I can get the normal tidal volume if I give say same I type, because the time constants in resistance, airway resistance is more. You need to give more time for filling also. If you don't give adequate time for filling, if you're going to give same time, even if you increase PIP, you cannot give same tidal volume. Understood?
Yes, sir.
So that's the concept. That's very important. So in resistance, you need to increase the pressure as well as time to fill the alveoli. Same thing, to empty the alveoli, you need to give more time. Understood? At least for filling, you can increase the pressure so much that you can, even with less time, you can fill the alveoli. But expiration is passive. You cannot do anything by ventilation also. So there you need to allow the lung to empty. For that, you have to give more time for expiration. You cannot shorten the expiration because the time constant for expiration is more. So your ventilator cannot control the expiration. That's why you need to give more time for expiration. Is it clear? We are going to discuss it again, but at least the concept of time constant you should know. When I'm talking about this specific ventilation, I'm going to talk about time constant again. But you should understand about what is time constant. Time constant is nothing but the time taken to move the air in or to move the air out. How much percentage is depending on 1, 2, 3 time constants. One time constant is 63%, two time constant is 86%. That's all. Normally, we need to give at least 3 time constants for the lung to go get the air in or get the air out. And inspiratory and expiratory constants can change depending on the lung pathology. That's what I'm telling. Can I move on?
Yes, sir.
The final respiratory mechanics, and this is the work done by your either by you or by the ventilator also, and it's mainly to overcome the resistance and to overcome the elastance. So pressure, what is needed is to overcome the resistance, one is known as elastance, and it can be both. So it can be the addition of your muscle power along with the ventilatory pressure. So sometimes if you want the patient to do more work, you can just decrease the ventilatory support. So patient also will do, so that weaning, when you're doing weaning, you keep decreasing the ventilatory pressures. So the patient will do the more work. When you're starting off your ventilation, you don't allow the patient to do more work because you need to give rest for the, because patient are tired off. So their ventilator will do more work, but once the lung get improving, you keep decreasing the ventilatory support. So you allow the patient to do more work. So one thing is you need to overcome the resistance. Other thing is you need to overcome the elastance forces. So that is the main thing is respiratory mechanics. For that, you need to have certain pressures. The one pressure which is to overcome the resistance is airway pressure, and what is the pressure which is to overcome the elastance is transthoracic pressure. So overall pressure is transrespiratory pressure. Transrespiratory pressure is nothing but airway opening pressure minus your body surface pressure. So elastance is the recoil force generated by your elastic structures. It's mainly it's the force which will not allow you to stretch the alveoli. Okay, I think it's 7:30. You want to continue or we'll stop it here? There's too much concept we cannot understand in one day. How many slides we have? We have the 10 slides. We'll stop here or we'll continue? I think we cannot focus more on if we continue also. So we'll end this. We'll start from where we stopped yesterday. And we have discussed yesterday about pressures, volume, and compliance, resistance, elastance, and about time constants. Now see, we'll go to certain variables which are needed mainly to tell the ventilator how to initiate a breath, how to stop the breath, how much it has to give the flows, and how much pressure is needed. It's all will be told to ventilator by certain parameters. So we'll see what are the variables which essential to for the ventilator to give breaths for the patient. So the first thing what we need is you need to tell the ventilator to start inspiration. And the second thing is you need to tell the ventilator you have to stop when inspiration at a certain point and you have to go to the expiration. And so this is the starting point of inspiration. So you need to start the inspiration, go, continue the inspiration, and you should not go beyond certain thing that is called limit. So you need to limit the inspiration to a certain extent. And you stop the inspiration and you move back to the expiration. And again, during expiration, you should not go below certain extent. You need to stop at certain extent. Then continue the expiration. So this is called the baseline pressure. And again, you start inspiration. And during this inspiration and expiration, the control of gas delivery will be mainly by the ventilators during inspiration only. It cannot control the gas flow during expiration. So ventilator can control only inspirated gas flow. So expirated gas flow is not under the control of a ventilator. It's by the recoil of the chest wall. So these are the variables which are essential for making us to control the ventilator and to design our strategies in ventilation. So in this orange one you can see it is the control variable. So the control variable is the variable which we can control directly. So say if I want to control the breath parameters by telling the ventilator that I need this much amount of this. So for example, if I able to control the pressure, like I tell the ventilator, you need to give a pressure of maximum of 21. The ventilator will give only the pressure of max up to 21. It will not go beyond that. So now I am controlling the pressure here. Beyond 21, it will not go. Below 21, it will not go. It will give exactly what pressure I said. And the most important thing here is you cannot control two variables at a time. You can control only one variable at a time. So either you can control pressure or you can control volume, and volume is indirect one. What you are going to control there is flow. So that the modern ventilators can control two things. One is the pressure control, other one is the flow control. By controlling flow, you can control volume. So in volume control ventilation, you are not controlling volume directly. You are controlling flow. Indirectly, you are controlling volume. In pressure control ventilation, you are controlling pressure. So you can control only two things, either pressure or flow, and by flow, you are controlling volume. If you control pressure, you cannot control volume. If you control volume, you cannot control pressure. So that is vice versa. So depending on that, what you are going to control, the modes will change. You are operating in the pressure control mode or volume control mode, depending on the control variable. And based on this control variable, if you set some settings, then other things will alter. So if you control pressure, volume will alter, and your inspirator flows will alter, your meditation can alter. So that are all conditional variables. The things which you cannot control directly and which can be altered because you are controlling one thing is a conditional variable. So other variables like phase variables. Phase variables are one which will tell when to start inspiration, when to stop inspiration, when to go to expiration, and when to how much to the pressure to be sustained during inspiration. So these are the phase variables. In that you have a trigger variable. Trigger variable is the one which will decide when to start inspiration. Limit variable is the variable which tells you how much amount of the maximum parameter, that is the volume or pressure to reach during inspiration. And you have a cycle variable which tells when to stop inspiration and switch over to expiration. So trigger variable is the variable which tells when to start inspiration. Limit variable, the maximum amount of flow or pressure you go to attain during the inspiration. And cycle variable is the variable which tells you to stop inspiration and go to expiration. And you already told any ventilator can directly control one variable at a time. It cannot control both variables, either pressure or flow. By controlling flow, it can control volume. You can see here phase variables. Phase variables. So this is the trigger variable which can start tells you when to start the inspiration. And this is the limit variable. It will limit the pressure or flow to a certain extent. It cannot go beyond that. And this is the cycle variable which tells you that you need to stop your inspiration and move on to expiration. So trigger, limit, and cycle variable. So these are the three important variables we should have to understand to know what are the different modes. So trigger, you have three parameters again in trigger. So one thing is time. You can set a time, inspire time of 0.6 seconds, expire time of 1.2 seconds. So at the end of 1.8 minute, 1.8 seconds, it keep on going to inspiration. Like breath cycle, what I'm telling is breath cycle. If you set a breath cycle of 2 seconds, let's say you set the rate of 30. So the breath cycle here is 2 seconds. So at the end of each 2 seconds, it's going to go back to inspiration. So you no need to control it. Automatically the time will trigger the inspiration. The main problem with time triggering is if the patient want to take a spontaneous breath in between, and it will not support that breath. It will not know. So like it will cause asynchrony. So you set a certain time and patient is breathing in between the time. So it will not support the patient breath. So that's why time triggering usually we'll use in paralyzed patients are not triggering much patients. Early ventilation period, use a try triggering. And later on, once the child starts adapted to the ventilator and he starts his own respirations, what we'll do is we'll go for auto trigger from patient triggering. So patient can trigger by 2 means, whether he can trigger by pressure or flow. So what will happen when patient takes inspiration? What will happen to the baseline pressure and baseline flow? Say, what is the baseline pressure in the ventilator? During expiration, what is the baseline pressure?
Five, sir.
Huh? Baseline pressure during expiration.
Beep.
PEEP, exactly.
Beep is 5.
Yeah. And baseline flow during expiration, at the end of expiration? At the end of expiration, what is the flow?
FR.
No.
No flow. At the end of expiration, once you stop at expiration, what is the flow? It's the baseline, not touch the baseline. Your flow
Zero.
touch the baseline, not touch the baseline.
Touch the base.
Touch the baseline is what the flow.
0.
Yeah. So now patient is started taking a breath, inspiration. He started initiating a breath. So what will happen to the baseline pressure and baseline flow? The baseline flow, that is the zero flow. So what will happen to the pressure?
Increase.
Above the baseline.
It will go above baseline. So you forgotten the physiology again. So
Negative.
patient is triggering spontaneous. It will become negative pressure. So
Negative.
your baseline pressure will become negative. But what happened to the flow?
No increase.
Increases.
Above the baseline, because it will going to suck the flow. So it will become a defect on the positive side only. So you can see here, with the flow trigger at the end of expiration, you can see it is touching the base and there is a zero flow. And what will happen when you start, patient starts breathing inspiration, the flow will become positive. You are going to tell the ventilator that if the flow becomes this much from the baseline, increase 20% increase from the baseline, you take it as a trigger and you start the inspiration. So you support the breath. Is it clear what I'm telling?
Yes.
You need to set certain parameter so that the ventilator will decide that, okay, patient is initiating. Now I have to start inspiration. So that can be done by you when you're setting a flow trigger or by pressure trigger. In flow trigger, it is going to increase from the baseline. So it will be positive. It will be in numbers of 1, 2, 3, 4, 5. So 1, 2, 3 means it's just telling the percentage. 1 means like 5 to 10%. It depends on each ventilator how much. Or in some ventilators, it can be directly the number can constitute to the flow of liters. And you can see the pressure trigger here. So during inspiration, the pressure from the PEEP is getting decreased. So it is going below. So when you tell the ventilator that if it goes below this much percentage of your baseline pressure, you need to start the inspiration. So if you set the time trigger, it's going to give the breath at the end of each 2 seconds. If the rate is 30, it's going to be at the end of 2 seconds. Or if you set flow or pressure trigger, it will going to assess the response from the patient, and the pressure, if it whether is decreased to a certain extent or flow increased by a certain extent, it will trigger the breath. It thinks that patient is breathing, so I need to give the breath now. The mainly pressure and flow trigger is mainly for synchronizing with the patient effort. So to mainly to prevent asynchrony. So see here, your pressure trigger is in the minus 1. Start with -1. It can go up to -20, and the flow trigger is starts with 0. It can go up to 10. And why these numbers are important? Because it will tell the sensitivity of the trigger. Sensitivity is nothing but you are going to tell the ventilator when to give the breath. If you trigger is like you set a trigger threshold that it is less sensitive. So what will happen now?
Machine will not respond with the smaller breaths.
Yeah. So the patient has to do more effort. The machine will not recognize that patient is breathing till patient will move the flow to certain extent, or patient will decrease the pressure to certain extent. If you keep the pressure threshold, like I need to get the breath only when the patient breathes to 80% of his baseline. That means he has to do more work. So for children, they cannot do that much amount of work. So we need to keep the sensitivity in the less threshold, like more sensitive triggers you need to keep, not the very low sensitive triggers. And if you keep very high sensitive trigger, like you tell that if the pressure or flow changes by 2 to 3%, you give the breath, what will happen now?
In a small changes, the machine
Okay.
So it is called auto triggering. So even if the water in the tube, it can detect it as a flow or the pressure, it can give auto triggering. Or if the chain is just not taking the, but he's moving a little bit, also it can trigger the ventilation. So that's why you should not give very much sensitive trigger, and you should not give very much low sensitive trigger. So it should be like an optimum trigger for that particular patient. So it depends on if the child has muscular weakness, you cannot keep like a normal sensitivity for normal patient. You need to decrease the sensitivity. Then only the ventilator will recognize. And say if you keep a normal trigger sensitivity and patient is breathing like 60, 70, 80 breaths, and sometimes you need to reduce that trigger so that the ventilator will give very less breaths. So it depends on the particular patient, particular disease. You keep on varying. The normal sensitivity, what you're going to keep. What I am talking here is the Mackett ventilator. So in Mackett ventilator, what we are going to keep is usually flow triggers in the pediatric population. And the flow triggers, what you're going to keep is from 4 to 6. Usually, this is the threshold we keep. 4 to 6. And the only disadvantage in Mackett trigger is they are crack people. So they don't want to follow the norm with other ventilators. They decided they want to change it in the reverse order. So like normally the pressure, if the -1 and -20, which is more sensitive, -1 is sensitive or -20 is sensitive?
minus.
Others, -1 is sensitive or -20 is sensitive?
Yes,
That means easily the ventilator can trigger what, -1 or -20?
-1.
-1. Like if flow 1 and 10, which is more sensitive? 1 is sensitive or 10 is sensitive?
1.
Yeah,
10 is
that is what usually you feel. Yeah, that's what I'm telling.
10.
That is what for normally all ventilators will do that. But the problem with the Mackett is they have their own algorithms. They don't want to follow other people's rules. So they changed it. Not for pressure, but for the flow only. Here, 1 is less sensitive. 10 is more sensitive. That is the only difference in Mackett. If you're using Mackett ventilators, you need to just know this one point. In Mackett, in flow trigger alone, less the number, it will be less sensitive. More the number, it will be more sensitive. But it will be opposite in other ventilators. It will be normal. The lower the number, it will be sensitive, high sensitive. More the number, it will be less sensitive in all other ventilators. And even in Mackett, for pressure, it is same principle. But only for flow, it will be reverse. So you see the diagram here, increase sensitivity. So from 0, you move on to 10, the sensitivity will be increasing. There will be more of auto triggering when you go to 10. So that's the only difference. If you are using Mackett ventilator, that's, you know, this is the must know point for you. So trigger 10 is more sensitive, trigger 1 is less sensitive. And in pressure trigger like -1 is more sensitive, -20 is less sensitive. That's all. There is no change in other ventilators for this. Only in flow trigger is a change in other ventilators. Except in MACAD, all of them behave like normal rule. 1 is more sensitive, 10 is less sensitive. But in MACAD, it's reverse. Just remember this one point for MACAD people. Is it clear till now what I'm telling? What is sensitivity of trigger? If trigger is very less sensitive, there's a risk of auto triggering. It keep on giving more breaths. If more sensitive, it keep on with auto triggering. If sensitivity is very less, it will not trigger. So even if patient is breathing, it will not give the breath. So high sensitivity, low sensitivity. So high sensitivity, it will be auto triggering. Low sensitivity, it will be missing the breaths. So patient will be struggling. I'm not getting breath. I'm not getting breath. So they go for asynchrony. So the main problem here is you need to give appropriate triggers, appropriate sensitivity triggers. So to prevent asynchrony. Then coming to phase variables, the limit. The limit is mainly pressure or flow. That's what I'm telling. If you select tidal volume, flow is the limit factor. And if you select pressure control, the pressure is the limit variable. You cannot go beyond certain pressure. If you set the pressure of 20, it will not go beyond that. And if you set a tidal volume of certain thing, and flow will be adjusted according to the inspected time. You're not going to change the time. So time is fixed, volume is fixed. So flow will be fixed. And it will go to certain extent, it will not go beyond that. So the phase variables in the limit variable is flow or pressure. And cycling. Cycling is the one which stops the inspiration, which can go to expiration. So what are the variables you can use for cycling? Which all you can set for to go for cycling? Think. Which variables you can use for cycling? Like during the triggering, you have 3 variables. So for cycling, when to stop inspiration and go back to expiration, what parameters can tell the ventilators? No, you can go for the expiration. Think and tell.
Volume trigger time.
Yeah, time is a common thing. So you set the inspirated time. At the end of that inspirated time, it's going back to expiration. Other things? Like
Flow.
Flow, yeah, flow. How to
Flow can.
how flow can act as a cycling variable?
When required tidal volume is reached, then we can change.
Yeah, then you can set a volume as a trigger, cycling the Y flow. Flow will be constant only, na? At the end of expiration, like if you set the volume, the flow will be constant. And how to tell flow that ventilator to tell you this flow is the cycling variable. So this much amount of the flow you need to shift over to expiration. So we'll see. So these are the parameters which can even volume, time, flow, pressure, all they can act as a cycling variable. But now the most of the ventilators, it's only 2 now: time and flow. So volume and pressure, now conventional ventilators, now they're taken off. Maybe in recent advanced modes they can be used, but the common thing is flow and time. Just about these 2 things. Time and flow are the cycling variables. That's all. So see here how the flow act as a cycling variable. You need to tell the ventilator that if the flow reaches 20% or 30% of the peak flow, so this is the peak flow, and it started decreasing. What flow pattern it is? What flow pattern I am talking here?
Decelerate.
Yeah. So can you select flow cycling in constant flow pattern? You understand my question? You have a constant flow pattern, volume control mode. Can you select flow cycling? Can you do flow cycling in constant flow pattern? Yeah, you cannot, because the flow is constant. It cannot going to decrease unless it reaches the expiration. That's why in inspiration, like decelerating flow pattern only, you can control the cycling by flow. The rest of all, you have to tell the time only. You cannot see there. So in decelerating flow, when the flow is decreasing, you can tell the ventilator that the flow decreases to certain extent, like 20%, 30% of the peak flow. This is the peak flow. It is 100%. And it is reaching, it's coming down, it reaches 20%. So here what happened? The ventilator switched off the flow and gone back to expiration. This is the flow cycling. Is it clear what I'm talking? So this is the peak flow, it's 100%, and you select a cycle variable of 20% of flow. So when the peak flow dropping, this is 20%, it not dropped further slowly. It abruptly ended and there it went to expiration. So this is called flow cycling. It will commonly seen in support modes. We'll see in that later on when we're discussing modes. Then controlling. So like I already told, when you control volume, it's volume control. When you control pressure, pressure control. In volume control, what you're controlling actually is flow. It is not the volume. When you're talking about volume control, what you're actually controlling is flow. By flow into time, you're controlling volume. And when you want to control both pressure and volume, you have hybrid controlling. So it can be hybrid controlling or it can be adaptive controlling. Adaptive controlling, we'll see what is adaptive controlling. It's like you're controlling both volume and pressure there. So how the difference between hybrid and adaptive controlling, we'll see in the subsequent slides. So this is the volume control mode, this is the pressure control mode. So which is constant? You need to see first whether flow is constant or pressure is constant. Which is constant that you are controlling? In volume control, which is constant? Pressure, volume, and flow.
Flow.
So what you are controlling? Flow is
Volume we are controlling.
No, that's what I'm telling. You are controlling flow. Your volume is not controlling here. Flow is constant, so you're controlling flow. By controlling flow, you're controlling volume. Actually, if you target, you're targeting volume. By controlling flow, you are targeting volume. That is volume control mode. In pressure control mode, your flow pressure is constant, so you are controlling pressure. You can control pressure, but you cannot target volume here because volume will change based on
Flow.
no. Flow is also depends on your volume generated. Compliance. So if you have normal compliance and low compliance, what is the volume generated? Compared to normal compliance lung, what is the volume generated?
Less.
Low compliance lung, when you use same pressure, say the pressure is 20 here. What will happen to the volume in low?
Decrease.
Less.
So that is what you cannot control volume in pressure control. So it will alter. That's what I'm telling. Say in volume, you set a volume control mode and you set a tidal volume of 6 ml per kg. So what will happen to pressure in low compliant lung?
Increase.
More pressure is required. More
More
pressure. is
pressure.
So is it clear now? So if your lung is bad, either you need high pressure or if you're not able to increase pressure, your volume will go down. So that's why depending on the mode, you need to see what is going to happen. If you put volume control mode, your volume is guaranteed. Your volume is like 6 ml per kg or 7 ml. What you said is going to deliver, but at the cost of high pressures. But the problem here is you need to set the pressures control there also. Maximum pressures. There's alarm setting called maximum pressures. So if you don't alter maximum pressures, your volume can be delivered low in volume control mode also. Say, for example, I'm targeting a volume of 150. For that, I need a pressure of 40. But in controls like alarm controls, I set maximum pressure limit to 30. What will happen now?
Liquid volume is not.
Yeah, volume is not delivered. And what alarm I get now? What is the first alarm I going to get?
Pressure.
Pressure, high pressure, high pressure. It is not. That's why if you don't see at that alarm, and finally child will have low tidal volume, child will desaturate. Is it clear? If you don't set your pressure to appropriate levels, even in volume control mode, your volume is not guaranteed. That's the first thing you need to see. If your volume is not delivering in volume control mode, you need to see for the pressure or need to see for the leak. Leak is there is some amount of air going away from the circuit. So there's are two things you need to see. If you're in volume control mode and you're not able to get your adequate volumes, the pressure limit is what you set is not appropriate, or there is a leak. And in pressure mode, your volume will not be guaranteed. So you set a pressure depending on the compliance of the lung, the pressure volumes will be varying. Suddenly the lung become low compliant, your volumes will go down. So you will not get the pressure alarm here. You will never get the pressure alarm here because you already set the pressure. So what you're going to get the alarm here is, if the lung becomes bad, what alarm you're going to get?
Low
Low
tidal.
tidal.
Low tidal volume or low minute volume alarm. So that is so alarm setting is very important. In whatever mode you keep, your alarm should be set appropriately. We'll discuss in the subsequent classes how to set the alarms. So I'm clear what is the difference between volume control mode and pressure control mode. Is any doubts here? If you control pressure, you cannot control volume. If you control volume, you cannot control pressure. That is the first thing you need to learn from this class. You cannot control both. So with this, we'll move on to the modes of ventilation. So I think if people are already ventilating few of the children, and there are different modes in the ventilation, and it's like a Greek and Latin. There are different names in different ventilators, and you look why this many modes. This is really mysterious to me. But what I'm going to tell is there are a lot of modes, but they're going to operate on the same principle. The principle is same, but the name is going to change. That's all. It is easier. You just need to understand what are the parameters which will decide what mode you are operating. And the different ventilators will have different names for different modes. But the basic underlying idea of the mode is same. So we'll see what is mode and breath delivery. So breath type and pattern of breath delivery during mechanical ventilation will constitute the mode of ventilation. Breath type and pattern of breath delivery. These are two important words you need to remember. So because I'm going to keep on talking the same thing in the subsequent slides. Breath type and pattern of breath delivery. So these are two important things. And by combining different breath types and breath patterns, you will get different modes. So type of breath, you have two breaths. One is mandatory breath and one is spontaneous breath. And you have a control variable, whether you're controlling volume or pressure or both, and timing of breath delivery. So whether you are going to a mandatory ventilation or intermittent mandatory ventilation or spontaneous ventilation. So these are three things which will determine your mode. So type of breath, what is the control variable, whether you control the pressure, volume or both. This both is because now we talk about hybrid modes. So we'll discuss about it later, but just remember, any hybrid mode also you cannot control both. You can control volume and pressure at a time. With the time you can change from volume to pressure, that is called hybrid modes. We'll see it later. But at any given point of the time, you can control only one. Even in hybrid modes, you cannot control both volume at a time. And timing of breath delivery. So breath types, it's based on two variables. One is the trigger and one is the cycle. You see here, if patient has full control over timing, the thing is he can trigger the breath and he can end the inspiration. He can trigger, he can end. Then it is a spontaneous breath because patient has full control over his inspiration. Patient triggers the breath, patient ends the breath. That is spontaneous breath. If patient have no control over both or he has control over one, then it's called mandatory breath. Patient controls both only spontaneous breath. If patient is not able to control both, it is mandatory breath. That's simple. In mandatory breath, if patient is triggering the inspiration, then it's called assisted breath. In mandatory breath, even if the patient is not triggering the breath, then it is called controlled breath. Confusing? Just remember. Just remember there's two things. One is trigger, one is cycle. That means one is going to start the inspiration, one is going to end the inspiration. If patient has control on both, it is what breath?
Spontaneous breath.
If patient doesn't has control on one variable, he can control one variable, he cannot control other variable. Then it becomes
Mandatory.
Mandatory breath.
in mandatory, the patient triggers the inspiration. It is
Assisted.
Assisted breath.
it has no control over inspiration at all.
Controlled.
Controlled.
That's all. There are three breaths. One is spontaneous breath. Second thing is assisted breath or controlled. Third thing is uncontrolled breath. But assisted or controlled will come to mandatory breath. So spontaneous, patient control everything. Mandatory breath, patient will control either one variable or no variable. In spontaneous breath, it can be supported or unsupported. If the ventilator supports the spontaneous breath, like press support mode, it can be supported breath. Or a patient triggers the breath and stops the breath, but the patient ventilator is not giving any support for it. It's unsupported breath. We'll see what the difference between support and unsupported breaths. So in mandatory breathing, it is ventilator triggered mandatory breathing. That is called controlled breath. If patient triggers, it is assisted breath. In spontaneous breath, it's entirely the patient. So work done by the ventilator will be more in mandatory breath. Work done by the patient will be more in spontaneous breath. It can interchange if you add support per support. Again, to summarize, in controlled breath, which triggers the ventilation? Who triggers the ventilation? Ventilator or patient?
Ventilator.
Ventilator.
Ventilator triggers the
Who cycles the inspiration? Ventilator or patient?
in control with ventilator.
Ventilator.
In assisted breath, who triggers the breath?
Patient.
Patient triggers the breath.
Who cycles the breath?
Ventilator.
Ventilator triggers the
Spontaneous breathing, who triggers and who cycles?
Patient.
patient only triggers, patient cycles.
Everyone understood this. It's very important. Until unless you know this, you cannot understand the modes. Yeah.
For the cycle patient, ventilator can be.
So, control means entirely by ventilator. Patient cannot. That's why it's called control breath. When patient is not triggering, he cannot control cycling. He can trigger only, he can control cycling. If it's not triggering, he cannot control cycling. That's why in control breath, it's entirely by ventilator. Only when patient triggers, he can control it cycling. When he is not able to trigger, he cannot control cycling. So if he triggers and is control cycling, that is spontaneous breath. Whether it's supported or unsupported, it depends on your decision. Can I move on? I think it's clear.
Yes, sir. Yes.
So see here, in controlled breath, the entire work is done by ventilator. In assisted breath, some part of the work can be done by patient, but majority of the work will be done by ventilator. In spontaneous breath, majority of the work will be done by the patient, but sometimes you can assist him if you're not able to finish the work. So next we'll move on to the breath delivery timings or sequences. In that we have continuous mandatory ventilation, intermittent mandatory ventilation, and continuous spontaneous ventilation. So continuous mandatory ventilation is commonly known as assist control ventilation. You can see the modes ACV mode, PCV mode. These are all mandatory ventilations. Here all the breaths are mandatory. If you set the rate, that will be delivered. If patient doesn't breathe, it's not going to make a difference here. If you set a rate of 20 or 30, the ventilator is going to deliver 20 or 30. Whether the patient will take a breath or not, it's not going to make any difference here. So the delivered breath can be ventilator triggered or patient triggered. You know that in mandatory breath, it can be assist control. It can assist the breath and it can be control breath. If ventilator triggers the breath, what is this type of breath it is? Is it control breath? If patient breath,
Assisted.
assisted breath. So all are mandatory only. All breaths are mandatory. But whether who is triggering here, patient is triggering or ventilator is triggering, it's going to change the name, that's all. So all patient triggered breaths also will be supported by the ventilator. To a certain extent, that is, if the set the rate of 30, it is going to give the 30. And spontaneous breaths for the patient will not be possible due to the mandatory breath. That's the main disadvantage in this mode. So it will not support the spontaneous breaths. So intermittent mandatory, here you will set the mandatory breaths like 30 or 20, it can deliver that number, and it will allow spontaneous breathing also. So in between, the patient can take spontaneous breathing. Whether to support the spontaneous breathing or not, that is decided. So how much patient can generate the tidal volume, that determines the volume in spontaneous breaths. In mandatory breaths, patient will be supported by the ventilator, so he can get the desired tidal volume. But in spontaneous breath, the tidal volume will be determined by the patient effort only. It will not be supported by your ventilator. But in certain modes, you can add, you can support them also. We'll see what are the other modes we can have. So you can support it by augmenting by adding pressure support. So now the other variant in intermittent mandatory ventilation is synchronized intermittent mandatory ventilation. What is the synchronization? You have intermittent and you have synchronization.
Synchronization with patient trigger.
Yeah, synchronizing with the patient inspiratory efforts. So you are synchronizing, you are telling the intermittent mandatory ventilation that you need to trigger, you need to start the inspiration with the patient efforts. How ventilator do it by? So ventilator will create a timing window. Say I set a rate of 30. See here, I set a rate of 30. So the breath cycle here is, what is the breath cycle? When I set a rate of 30?
2 seconds.
2 seconds.
2 seconds, 1 breath.
I set a I ratio of 1:2. So what is the inspiratory time?
0.6.
So 0.66. So the ventilator will take a time of around 0.2 seconds and it will create a synchronization window. You can see here synchronization window. My mouse is moving. Is it visible?
Yes, sir. It's good.
Yes,
Yeah,
sir.
synchronization window. You can see here. And if the patient start a breath in this window, it will synchronize the patient. It will give the breath. What breath it is?
It's assisted.
Mandatory, and it is assisted breath because patient taken a breath here. And if patient takes a breath in between that window of 2 seconds, we set a rate of 30, right? So it is 2 seconds is the breath cycle. In the same cycle, if patient takes a spontaneous breath, it will not assist again. See here. And again, At the end of 2 seconds, it will give the window again, like 0.2 seconds window is there. If the patient not triggered here, what will ventilator will do?
Hold the breath.
It will give
The patient will start the breath.
what breath it is?
Ventilation.
What breath it is?
Control.
Control.
Mandatory breath.
Control breath.
Control.
All are mandatory. If you set a rate of 30, all 30 are mandatory only. That if the patient had a spontaneous effort and ventilator supporting it, it's called assisted breath. If patient is not able to trigger, it becomes
Control.
controlled breath. That's the difference. In between, patient can have spontaneous breath. See here. In between, child is having spontaneous breath, but here we are not supporting that breath. So these are called spontaneous breath. The patient is triggering, patient is cycling. Ventilator is not doing anything. So this is spontaneous breath, and here it is assisted breath, and this is the controlled breath. These two are mandatory breaths. This is called synchronized intermittent mandatory ventilation. I think I'm clear on this.
Yes.
Synchronized intermittent
Yes,
mandatory.
sir. Yes, sir.
All three breaths: spontaneous breaths, assisted breaths, controlled breaths. And what is the synchronization here is, it will create a window just in front of the inspiration, and the patient triggers the breath during that window. It will assist the patient breath. And if the patient is not taking the breath, it will give the controlled breath. So your set rate is delivered. If you set a rate of 30, 30 will be delivered. Whether it's a patient triggered or not triggered, it doesn't matter. But in between, patient can have breaths. Patient can take 30 or 40 breaths extra in between, but they will be supported or not supported depending on your preference. Okay, it's clear. Now we'll move on to continuous spontaneous ventilation. Here all the breaths are triggered by patient, cycled by patient. So no mandatory breaths. If the patient is not triggering, ventilator will not give the breath at all. That's the main difference. If the patient doesn't trigger, the ventilator will not give the breath. And this spontaneous breaths can be supported or unsupported. So examples are CPAP and PSV. In CPAP mode, patient will keep on generating his own spontaneous breathing, and just you are going to provide the PEEP for the patient. And if you add pressure support to that CPAP with PS, that means all spontaneous breath will have some assistance from the ventilator. And what is the cycle here for spontaneous breathing? What is the cycle parameter? So we know what are cycling parameters, you know?
Time of flow.
Time and flow. So what will be the cycling parameter in this spontaneous breathing patients, CSV? Can you give time for cycling here?
Patient is cycling.
That's what I'm telling you. We have two parameters here. One is time and one is flow. So what can act as a cycle for spontaneous ventilation?
Flow.
It's flow. It never time. Because if you set certain time, patient will not follow the same time pattern. It can have different time patterns. So you cannot give time as a cycling variable in spontaneous ventilation. That is the main difference between mandatory and spontaneous ventilation. In spontaneous ventilation, is the patient who is controlling the cycle variable, and patient can control it by only, ventilator can detect it only by flow, not by time. Because the patient can vary the time. So each time the ventilator cannot detect the patient time. So that's why you're telling the ventilator to get the flow. It's a flow trigger. It's always you need to set the flow. Either 15%, 20%, 25%, 30% of the peak flow. If you set that and the flow from the peak flow reaches the 20-30%, it will switch over to the expiration. This spontaneous breath PSV can be used in any mode. Any mode. We label assist mode, assist control mode, like a CMV or SIMV. You can add this present support mode, assist ventilation for spontaneous breaths. So see here, what is the first one? What is this mode?
Mandatory.
All breaths here are
Ventilator.
Mandatory.
mandatory. There is no spontaneous breathing in between. So it is continuous mandatory ventilation. The second mode is
Intermittent
it
mandatory.
is,
Intermittent mandatory.
so it is intermittent mandatory. If you add synchronization window to this,
Synchronized
Synchronized intermittent mandatory.
intermittent
Ventilation.
so the last one is there is no mandatory breaths here. All are spontaneous breaths. So it is continuous spontaneous ventilation. Now you need to answer here. So what is the first breath here?
Mandatory.
Mandatory.
Control.
Variety of mandatory.
Control.
It's a control.
Control.
So this is this one is
Spontaneous.
spontaneous.
Content.
What happens to this breath? Is supported or unsupported?
Unsupported.
unsupported.
Supported.
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 You are getting extra pressure here. If patient takes a breath, this much only he can take, up to this much only. But you are supporting his, so the pressure can go up this much. This is called pressure support. So you can add pressure support. This is called SIME plus pressure support. This is the commonest mode routinely used. And see here, and the volume generated in these two supports will never be equal. If you are supporting to the same extent of the mandatory breath, then what is the difference setting a rate here? See here, what I'm telling is, if you support it to the full extent and the tidal volume generated during the spontaneous breathing also reaching that of the same of the mandatory breath, you can just increase the rate, right? Why you want to decrease the rate to 20 and support all the breaths? What is the main advantage of giving the patient to spontaneous breathing?
We know.
Yeah, you are allowing the patient to do work so that you can wean the ventilator off. But if you're supporting the spontaneous breath same as the mandatory breath, there's no point of decreasing the rate. You just can increase the rate so that all the breaths will get the same tidal volume. Remember that one point, that in pressure support, when you're giving pressure support, it should never be equal to the pressure control. If you are giving pressure support equal to pressure control, there's no difference between SIM and SIMPS. You can just increase the rate to 30 or 40, whether desired rate, and just to give the pressure control. No need to give the pressure support also. So always remember, your pressure support should never be equal to pressure control. It should be always less. If you are supporting equally to the mandatory breath, there's no difference between mandatory ventilation with pressure support ventilation. All are same. All become assist control then. So what is this breath here? That breath.
Assisted.
Assisted and synchronized. It's in the window. So assisted and synchronized. So is it clear? So you have a mandatory controlled breath. You have a spontaneous breath which is supported by PS, and you have a synchronized assisted breath. So this is SIME plus PS ventilation. So it's same to summarize. In CM, what is the breath type? All are mandatory. All are mandatory. There is no other things. Mandatory can be assist or control. And what is support from ventilator? Does all the breaths will reach get the support from ventilator?
Yes.
Yes. So in mandatory ventilation, all the mandatory breaths will get support from the ventilator, and it will not allow the spontaneous breathing. IMV, it has mandatory spontaneous breaths. All mandatory breaths, again, they get support from the ventilator. Spontaneous breaths, whether they get support from the ventilator or not, it depending on your choice. It's not the ventilator choice. If you want to support them, you can support them, and your support should never be equal to that of the mandatory breath. If you're doing that thing, there is no difference between CMV and IMV. And in CSV, all are spontaneous breaths. There's no mandatory breaths, and you can support or you cannot support them. Why you need to know this? Because each mode has advantage, each mode has disadvantage. You should know that. Then only you can choose what type of mode I need to use. In CMV, the patient will do the less work. So it's more advantage the patient when the patient is very much tired off and less asynchrony. You're not allowing the patient breathing, so there's less synchrony. And it can be used in apneic patient as well. The problem is you can easily hyperventilate the child. So if you set the rate of some 30, and if the patient start breathing and you allow the patient get the full support, because all the breaths, if the patient triggered are mandatory. Before that, what I'm going to tell is now all the ventilators, there is no pure CMV now. All are assist control modes only. So the patient takes breath, they're going to assist them. So the CMV, pure CMV modes are taken off. The new ventilators, it's only assist control. Assist control means you set the rate, that rate will be delivered. Beyond that rate, if the patient triggers, he'll get the full assistance from the ventilators, like the same of the 30 breaths. Like, if you set up 30 breaths, and all 30 breaths will get the pressure control. Even if the patient breathes extra, he'll get the same support of pressure control. He will not get the less support from that. So that's why in assist control ventilation, which is commonly previously used as continuous mandatory ventilation, now the term is changed to assist control ventilation. In assist control ventilation, if the patient is breathing, that is assisted mode, assisted breath. If patient is not breathing, it is the control breath. That's why assist control ventilation. But its main principle behind that is continuous mandatory ventilation. Patient triggers, fine. Patient is not triggering, you get the requested breaths. Like you request of 30 breaths, he'll get 30. If don't request 30, you request only 20, he'll get 20. Beyond that, if patient is breathing, he can get the assistance from the ventilator, that is called assisted breaths, and they are equal to that of the mandatory breath, like your set rate of 20. But all are mandatory. Whether patient is triggering or patient is not triggering, the set rate will be delivered. If patient is breathing more, he can get assistance fully for even for the extra breaths. Like set rate of 20, patient is breathing at 50. Even for that extra 20, patient will get the full assistance, not like other modes like in IMV where you get the less assistance. Like you put the pressure support mode, your assistance will be less. But in CMV, I will call it as assist control, ACV modes. In ACV modes, whatever the patient takes, 30, 40, 50, whatever extra breaths he can take, he will get the full support. That's why he can do hyperventilation. He can wash out the CO2s. He can generate more minute ventilation. So the problem is that the main disadvantage with this ACV mode is if patients start triggering, he can go for hyperventilation. And certain times he can have breath stacking. We'll see what is breath stacking in graphics class. And they can go for muscle atrophy because when patient is not doing work, he will relax. Ventilator is doing the full work, your muscles will get atrophy. That's the main problem in CMV. In IMV, there's a less chance for hyperventilation because you are not going to support fully for the spontaneous breaths, and you will allow spontaneous breathing. You just allow them spontaneous breathing, and you can use it in an apneic patient as well. Because if you patient is apnea, what will behave like IMV mode behaves like? In apneic patients, I will behave like
Control mode.
Yeah, that's all. So even you can use it in apneic ventilation, and so child will have variable work of breathing. So during spontaneous breath, if you're not supported well, child has to do the more work. So there is less chance for muscle atrophy here, and you can use it as a weaning mode. That is the main advantage of intermittent mandatory ventilation. In CSV, it is mainly weaning mode. You cannot start in a paralyzed or apneic patient. So that's the main disadvantage for this. CSV is a weaning mode. You cannot start it ahead during ventilation, because during the starting of ventilation, you're going to paralyze the patient for putting ET tube. You cannot straight away put them on CSV. So you start with CMV. Once child woken up, you switch over to IMV. and fully awake child and you already weaned off the pressures, you can switch over to CSV. This is what you will follow. So controlling ventilation, I told you, you can control volume or pressure, you cannot control both at a time. So the first graph here is what control?
Volume control.
Because the flow is constant. Here, which is constant?
Pressure control.
That is pressure control. So in volume control, flow is constant, volume is varying. In pressure control, pressure is constant. So just to see which is horizontal one. So the more horizontal one is constant one. So in flow is constant, that is volume control. Pressure is constant, that is pressure control. So already we discussed this. In volume control, pressure will be variable. So when you have lung compliance poor, what will happen to your pressure?
Increase.
Yes, to deliver the same tidal volume. In pressure control mode, if your lung become worsen, what will happen to your volume delivered?
Decrease.
You can see it here. So pressure is constant, but the volume generated is decreased depending on the compliance. So what mode it is?
SS.
What is the constant here?
Pressure.
So pressure is constant. What is the flow pattern here?
Decelerate.
Yeah, this is decelerating flow. So remember that one thing, in pressure control, the flow pattern is always decelerating. You cannot get any flow other than this. Pressure control, the flow is always decelerating. You cannot get any other flows. And what are the parameters you're going to set in pressure control? See here, what you're going to set? You're going to set the FiO2. You're going to set
P.
Rate, pressure. This PC above PEEP is delta P. And if you combine this delta P and PEEP, what it is?
PAP.
PIP.
PAP.
Some ventilator, they'll give directly PIP. They will not give this PC above PEEP. They will give directly PIP. So you need to be very careful what you are controlling there. So if you set a PIP of 20, then what is the delta P? You set a PEEP of 5 and PIP of
15.
50. So when you are setting PC above PEEP here, if you set PC above PEEP here as 20, what is the PIP?
20.
That's the main difference. So you should not confuse. So go back and check your ventilator. What is the second variable you are controlling? Whether it is the PIP or it is the PC above PEEP. PC above PEEP is the delta with the PIP and PEEP. But some ventilators will directly do PIP. So there you need to calculate what is the delta P needed, and you need to add it to that, and you need to directly set the PIP. And what you can set here is IE ratio. And what is this T inspirator rise? What is this T inspirator rise here? The T inspirator rise is the rise, how much fast the pressure reaches the peak pressure. See here. This is the slope. This slope is determined by T rise.
సార్ మరి ఒక చైల్డ్కి 50 స్లాబ్స్ ఈ రోజు బేబీకి చేయాలి సార్. అయితే అతను ఇప్పుడు
So T inspirator rise is the determinant of the slope. Whether the slope should be very steep or it can be little bit lower slope. So if you increase the T rise, if the T rise you increase to from 5, your slope is like this. If you increase the T rise to 15, what will become the slope? It will become more towards left side or right side?
Left.
Left or right? You are increasing the time. You increase the time taken to reach peak. The slope moves towards right or left.
Right.
So it gives you more time for the present to reach the peak pressure. So you understand what I'm telling? So the percentage is a percentage. This is a percentage means you are telling the ventilator you should reach the peak pressure in this percentage of the inspirated time. If your inspirated time is 1 second and you set the T inspirated rise of 10%, that means when you are going to reach your peak pressure,
0.1
1 second.
0.1 second.
Yeah, you are going to reach the peak pressure in 0.1 second. And you set the inspirated rise time of 20%. When you are going to reach the peak pressure, so 0.2. Understood? And what you are going to set here? Other parameter, what is this?
Flow through.
So what trigger it is? Flow trigger, pressure trigger here now.
No.
Yeah, if you have plus number,
Flow trigger. Flow
if you have minus number, it is pressure trigger. That's why it's very simple.
pressure trigger.
Yeah, here it is flow trigger because the number is positive. What mode it is? So it is volume control.
Volume control mode.
Because what is constant here? Flow is constant.
Volume.
Flow is constant. See here, this flow is constant.
Flow is
That's why you have this is the volume control.
Control.
What you are going to set here is tidal volume. There is no PC above PEEP here. PEEP is constant. PEEP, FiO2, rate, IE ratio, trigger, all are constant. One variable which is going to change here is tidal volume. Instead of PC above PEEP, you are going to directly select the tidal volume here. And there's an extra parameter called T-pause. So T-pause is the time you're going to tell the ventilator at the end of inspiration, you need to give certain amount of pause before switching over to
Next inspiration.
expiration, not inspiration. Can you see here? This is the flow curve. So at the end of inspiration, what has happened to your flow? Flow is not becoming negative. What has happened to flow here? Baseline. So this is flow state. It is a zero flow state. So when you have patient in inspiration and you have a zero flow state, what is the pressure you can generate at the time? Patient is in inspiration and there is no flow. So what is the pressure at that point of time?
Negative pressure.
P plateau.
no flow.
Yeah, it is P plateau. So you can see here, the curve here. What is the P plateau here? This is the PIP and this is
P plateau.
so in volume control mode. If you select T-pause, automatically you can get plateau pressure. It will be shown. You don't need to put the inspirator hold. Only in pressure control, you need to select the inspiratory hold button to make the ventilator stop the flow. Understood? And there is the new ventilators. You can have variable flow even in volume control. You can see here. See here. In volume control, you can select the flow pattern. The first two are constant flow. What is this flow?
Variable flow.
Yes. Even in volume control, when you are controlling flow, you can change the flow pattern. That is the decelerating flow can. But just by seeing the flow, you cannot tell it's volume control or pressure control in new ventilators. But for exam purpose, another purpose, if flow is constant, it is volume control. Pressure is constant, it is
Pressure control.
but you need to check in the ventilator what you're controlling actually. Even in volume control, you can have a decelerating flow. So by just seeing the flow, you cannot tell it is volume control with the new ventilators. So whenever I given this like this, and you have a decelerating flow here. What is the volume? What is the control you are controlling here? The pressure graph is like this. Pressure is not constant, and your flow is decelerating.
Volume control.
Yeah, it's again volume, because there's no constant pressure or constant flow here. Understood? If you have a constant pressure, it's pressure control. But if you don't have constant pressure like this, and even the flow is not constant, you can tell that it's volume control, decelerating flow. So that's why when you can able to modify the flows, you can change the flow pattern as well in volume control also. The most important thing is you should know what are the advantages and disadvantages of each control. In volume control, what is the advantage? What is the advantage of volume control? Why you need to use volume control?
To maintain the tidal volume.
Have constant tidal volume. By controlling tidal volume, what you can control actually?
Pressure.
Oh, it's not pressure. Tidal volume into something you have to put.
Respiratory.
So what you are controlling?
Minute ventilation.
That is the main advantage of volume control. What is the main disadvantage of volume control?
Pressure cannot be
To
controlled.
reach the pressure is not under our control.
So it can cause barotrauma. So what is the main advantage of pressure control?
Prevents barotrauma.
We can avoid barotrauma.
Barotrauma. And one more thing is there, it's about synchrony. So it can have more synchrony in pressure control than volume control, because what is the flow pattern in pressure control?
Decelerating.
So during the initiation of the inspiration itself, the patient will get the more flow. So he will be satisfied. So he will not do the work then. Once he get the flow, the peak flows during starting of inspiration itself, he will not do more work. But in volume control, the flow is constant. So it is giving only certain amount of flow. The patient needs more flows, it's not going to give. The patient will feel that, no, I am not getting adequate flows for me. I am breath hunger. So that's why he start taking deep breaths. So the asynchrony will be more in volume control than pressure control. So that's the main advantage of your pressure control. So your asynchrony will be less. And one more important thing is leak compensation. In volume control, you set a rate of 160, or volume of 160, and 40 ml is getting leaked out. So what will happen? What is the volume delivered to the patient? 120 only, so it will be decreased. But if you set the pressure of 12, with the 12 pressure, child can deliver get a volume of 160, and child is having that it is having leak also. So what will happen now? The ventilator will detect that the pressure is not getting delivered adequately. It can check the pressure. So even if the leak, the flow is going out, the pressure delivered to the patient will be less. So what ventilator will do? It will increase the flows to get the desired pressure. So you can at least control desired tidal volume in patient is having leaks. And one more advantage is in stiff lungs like ARDS and pneumonia, your decelerating flows, because you are going to give sudden gush of air in, so it can open the stiff lungs. That's the one advantage. That's why in newer modes like PRVC modes, you are combining the advantage of pressure control in volume guarantee. So that's why in previous slide you seen here, even in ventilators, they are giving decelerating flow in volume control mode. That's the advantage. So you want the advantage of pressure control in volume guarantee. So it's actually like you are controlling the pressure, but you are guaranteeing the volume. That is the main difference in this. But the disadvantage in pressure control is you get a variable VT depending on the lung compliance. So sometimes the lung is becoming more better, like you are ventilating ARDS child and you are on high pressures, and suddenly lung is improving. What will happen now? What will happen to your delivered volume?
Yes.
volume get more, increases, so you can get volume trauma. And lung becoming bad, your volume is not delivered, so your minute ventilation is not maintained. That's the main difference between this. So in volume control, you deliver a standard volume, and so that you have maintained the minute ventilation. The main disadvantage is more asynchrony, pressure is variable, chance for barotrauma. In pressure control, you have superior synchrony, you have leak compensation. In stiff lungs, it will help better. The main disadvantage is your volume is not guaranteed, minute ventilation is not guaranteed, and you can have volume trauma. This is very important because the modes are decided. You need to choose what mode you need to select based on these advantages, disadvantages. So I'm going to skip this. So at the end of this session, I think you are all feeling this. What mode, volume control, pressure mode, yeah, everything is same. So it's not that simple. We have time to finish this. Adaptive control, or we'll end this because already time is 7:30. Let me finish it quickly because we already covered the pressure control, volume control. It's easier for to understand adaptive control. So what is the advantage of volume control? What is the advantage of volume control?
Tidal volume and
minute
stable tidal volume and minute ventilation.
It have a standard tidal volume. What is the advantage of pressure control?
prevents
You
Barotrauma.
can avoid barotrauma.
It has better synchrony. That's the first thing you need to tell. Pressure control has better synchrony. Volume control will use stable tidal volume. So now we need to combine both. We need to have both in a mode where we get a stable tidal volume along with the better synchrony. So that is called adaptive controlling. Again, I am telling, even in adaptive controlling, you are not going to control both at a time. You are going to control only one parameter at a time. You cannot control both. Then why you are calling it adaptive control? So how can I get? How can I control volume? How can I control pressure? And that we'll see how we're going to control it. So what is the main difference between pressure control and adaptive controlling is you are going to control the pressure. Here in pressure control, you set the pressure, it is fixed for every breath. It is not going to alter. If you set a pressure of 20, it is going to deliver 20 pressure for every breath. It's not going to change it. But in adaptive controlling, it's going to be regulated. The breath, in each breath, what you're controlling is pressure only. But that pressure, how much amount you're going to deliver, it will be controlled by ventilator. There is the pressure control. One breath it can give 20, other breath it can give 25, other breath it can give 15, depending on the tidal volume which is generated. So by controlling, by altering the pressure, but it's going to deliver certain pressure only. It's not going to change for that particular breath. If that particular breath is going to give 15, it's going to give 15. It's going to give 20, it's going to give 20. It's not going to change it during that breath. You understand what I'm telling? In pressure control, for every breath, you're going to get same pressure, 20, 20, 20, 20. Because you're going to set the pressure. In adaptive controlling, you're not going to set the pressure. You're going to set the volume, but based on the volume delivered, the ventilator will adapt to the pressure. It keep on changing the pressure to get the set tidal volume. We'll see how it's going to be. This is called PRVC mode. This is the common name for PRVC, but it can be changed in different ventilators. But the market ventilator is the PRVC mode. So this is how it's going to control the pressure. The first breath is going to give the test breath. So the first breath is volume control breath. It gives the volume control breath. It will measure the pressure. Okay, for giving 180 ml tidal volume, I need 25 pressure. Okay, the next breath is going to give is pressure control breath. So it measured the volume It's given the pressure control breath and it will compare to the set breath. And it will never give the same amount of pressure what it measured. So in first breath, volume control breath, we set a tidal volume of 180. It will deliver the volume of 180. The pressure needed is 25. It will never give the same 25 in the second breath. It's going to give 23 or 22 and see what is the tidal volume generated. If the tidal volume generated is equal to that set tidal volume, for next breath, what is the pressure going to give?
Same.
Same. That's all. So it is going to give 22. Say, suppose my patient next time taken a little amount of breath. He given some amount of generated some amount of tidal volume by himself. First breath is volume breath. Ventilator decided that pressure need is 25. But it not given 25, given 22 for the next breath. This time the volume generated is same 180. So the third breath also it's going to give 22 pressure. But this time what my patient did, he generated his own breath and he generated some tidal volume extra, say 20 ml. And ventilator given the pressure of 22. So what is the total tidal volume delivered now? 180 by the ventilator, 20 by the patient. So what is the total tidal volume delivered now?
200.
200.
So what the ventilator will think now?
They're not sufficient.
Not sufficient.
More pressure is given.
Even more increases the pressure.
I given more pressure. So what it will do now?
Decrease
Increase
pressure.
pressure for next breath.
It is going to decrease the pressure for next breath. It's going to give only 20 now. And suddenly my patient stopped breathing. He not generated any tidal volume now. And ventilator given only 20. So what will happen now?
Increase pressure
Tidal
for next
volume
breath.
is not.
Tidal volume will be delivered less. So from 180, it will become only 160. So now what ventilator is going to do now?
Increase pressure for next breath.
It is going to increase the pressure. So in type of ventilation mode, what are you actually controlling in each breath? Pressure. You are not controlling tidal volume. Is it clear? But your volume is guaranteed here. But it's not during each breath. It in the subsequent breaths. Yeah, exactly. It's a volume guarantee mode. Someone in the chart they put. So it is volume guarantee with pressure control. You are controlling pressure during each breath, but volume cannot be the same during each breath. It can be variable, but the ventilator will try to match it in subsequent breaths. You can see here, this is set tidal volume. The volume shoots up, it's going to decrease the pressure. The volume is delivered less, it's going to increase the pressure to meet the desired tidal volume. Yeah. Yes.
If patient is not breathing 180 ml, it will 180 ml will generate.
Yes.
Then why?
The patient is breathing, no problem. Patient is not breathing, the entire thing will be delivered 180 the same pressure. It's not going to alter. If the lung improves, what will happen? Say patient is not breathing. Child needed 22 pressure to deliver a tidal volume of 180. The ventilator is giving 22 constantly. Volume is 180. The pressure is given in a decelerating flow pattern. My lung improved now. So what will happen to your tidal volume? Tidal volume is going to increase. So what ventilator is going to decide now?
More pressure is there.
It is giving more pressure, so it is going to decrease the pressure. So what is preventing actually?
Volume.
Advantage of the pressure control mode, right? So you are combining the advantages and nullifying the disadvantages by this method. You are getting the advantage of volume control advantages of pressure control and nullifying the disadvantages of volume control, disadvantages of pressure control in the same mode. So that's why if you don't know any mode, use this mode. That's all. But the main disadvantage in this mode is, like previously told, in spontaneously breathing patient, it will be very hazardous. So see here, adaptive controlling is not volume controlling. See here, these graphs. So this is what control? The first one is volume control because flow is constant. These two are
Pressure.
but this one is actually adaptive control. This is a PRVC mode. The graphs will be same, but the volume will be guaranteed here. See here, this is the starting of PRVC. What is the first breath here?
Test.
It is volume control. The first breath is test breath, is a volume control breath. And see the pressure here. What is the next pressure here?
Constant.
But what is the amount? What is the amount of PIP when compared to these two breaths?
Increase.
No. The first breath you have high pressure. The second breath always it's never going to give the same pressure again. That's what I'm telling. It's going to decrease the pressure. And what is the volume delivered now here?
Decrease.
Low volume.
So what happens to pressure here?
Increase pressure.
Increase.
Here? Increase, but reach
Volume same.
the set volume? No. So again, what it did? So what happened?
Increase the pressure.
Increase volume.
It reached to the set volume. So this is how your APRV mode works. It's keep on increasing the pressure to reach. The main principle in PRVC is the ventilator will decide the pressure, what is the minimal pressure needed to get the site tidal volume by giving the test breaths, 1 to 2 breaths, and will decide. So I need to give this much amount of pressure to get the tidal volume. That is the advantage of PRVC. It limits the pressure. It will prevent the barotrauma. It's going to prevent the volume trauma. So see here, if I put this graph, what are you going to tell? If I don't reveal the name here, what is the mode it is?
Pressure.
Pressure.
Pressure control. But what are parameter setting here?
Tidal volume.
If you graphs are pressure control graphs, what you are setting is tidal volume, what mode it is?
PRVC.
PRV. That's all. That is simple. The name can be different in different ventilators, but the principle is same. Adaptive controlling. Adaptive controlling is PRVC. You are going to get the desired tidal volume, but what you are controlling is
Pressures.
pressure. So you are not controlling volume, you are controlling pressure. Is it clear? The main disadvantage of PRVC mode is when the patient starts breathing, the volume delivered to each breath keep on varying depending on the patient. Patient do more work, less work, more work, less work. The volume will be varying. So it is not to be used in a patient with spontaneous breathing. The patient do more work, the next breath, he'll get less support. The patient stops breathing that breath, the volume will be less. If patient does less work, it will give more pressure. Patient will do more work, he'll get more volume. So that is the main problem with the adaptive control. So if the patient is spontaneously breathing and his breathing pattern is varying, sometimes he's breathing more volume, he's breathing less volume. So the ventilator cannot adapt to it. It keep on changing the tidal volume delivered, so it will be bad for the patient. So that's why APRV mode is less used in spontaneously breathing patients. We cannot use it as a weaning mode. It is for starting mode. And the other modes called hybrid control. In hybrid control, you can control both variables in same breath. See here, you have started as a pressure control. And what happened here? See this graph. This is a flow graph.
Constant.
It started as a control. It switched over to
Constant.
constant
Volume control.
volume control.
Volume.
That is the main. Is this called hybrid? In the previous one, it is not hybrid mode. It is adaptive. It is controlling only one variable. It's pressure. It is not controlling volume there. It's controlling pressure, but it's targeting volume. But here you're controlling pressure and you're controlling flow in same breath. And these are the latest modes, and don't worry about this. Don't forget about this. You don't need to learn about this also. I'm not going to teach you about this. This is what the real hybrid modes. They can control pressure and volume in the same breath. You don't need that. So in volume control, what is the control target?
Flow.
What is the control target? I'm not getting answers.
Flow.
Flow. What is the trigger?
Time.
Either time.
Can be time, can be
Flow.
Flow.
Pressure, flow.
can be flow. Any mode, you can have all these three: time, pressure, flow. What is the limit variable here? In volume control, what is the
Volume.
volume is the limit, and what is cycle variable? Mostly time. In old ventilators, we can have volume cycle also, but it's not in new ventilators. It is only time. Unless it is spontaneous ventilation, you are going to cycle only by time in new ventilators. In pressure control, what is your control?
Pressure.
Pressure.
What is your limit?
Time. Pressure.
Pressure. Your
Time.
limit is pressure, because it cannot go beyond that pressure. In PRVC, what is the control?
Pressure.
What is the limit?
Pressure.
Tidal.
No. It's not
Flow.
Pressure.
pressure only. The volume can vary. In pressure support mode, what are you controlling?
Pressure.
No.
Pressure.
Pressure. What is the trigger here?
Flow.
It is not pressure trigger. It will never be time trigger because there is no time here. And what is the cycle here?
Flow.
Flow. I think I'm clear. This is a summary slide. And based on this, you label the modes. When you are controlling volume, you put in the CMV mode, it is volume CMV. When you put in SIMV mode, it is volume SIMV. So when you control the pressure, it is pressure CMV, pressure SIMV. When you do adaptive controlling, it's adaptive CMV, adaptive SIMV. In support modes, you cannot keep the volume control because it is only pressure control there in support modes. So it is PSV, and when you do adaptive controlling, it is become as a volume support. Adaptive support means keep varying with each breath, like your PRVC. Don't need to remember about this. So in CMV modes, indications are patient is paralyzed, passive, and it's only partly active, and you cannot use in active patient because it can lead to hyperventilation. In SIMV modes, you can use in any patient. Any patient you can use SIMV mode. So if the patient is not breathing, it will become like
Mandate.
it becomes CMV. The patient,
PLV mode.
and patient is breathing, it will become SIMV, intermittent mandatory ventilation. Patient is taking spontaneous breaths, you set the low rate. It will become like a
Pressure.
spontaneous ventilation mode. You decrease the rate, you make the rate to 0, and you set the pressure support. What will become now?
Continuous spontaneous.
Right.
Spontaneous ventilation, that's all.
Mandate.
No, spontaneous.
Spontaneous.
You set the mandate rate 0. Mandate rate 0 is not mandate anymore. Patient has to trigger. In support modes, you cannot go for a passive patients. Not going to go for a partial active. You can. It's only for active patients. You need to. It's a weaning mode.